Okay, any questions on any farm stuff from last material? You guys have already forgotten probably most about it, but that's okay. We'll refresh you on it. So we're talking about therapeutic drug monitoring. Does anyone remember what that is? That is a great way to put that. You check the drug levels to make sure the patient's in the right range. That is, I could not have put it more succinctly myself. So we'll see how we do that. We'll see why we do that and kind of what we can do there. So you guys remember how long it takes to get to steady state? 4 to 5 half-lives, yeah. So again, remember how you can have very long-acting drugs that take forever to get to their steady state. You can have some short-acting drugs that will get to steady state very quickly, right? So I mentioned there's an antiarrhythmic called amiodarone that has a half-life can range anywhere from like 20 to say like 100 days. So say, you know, average 50 some odd days. How long would that take to get to steady state? 200, 250 days, like that's way too long, right? So we'll see. And you guys remember how we can get around those kind of drugs that have those really long half-lives to get to steady state more quickly? Yeah, we can do a loading dose, right? So basically a big bolus dose and get them up to their steady state level to begin with. But anyway, so we'll see that when you're measuring drug levels for a medication, you're going to have kind of two scenarios. One of which is that you get an adequate response. And you go ahead and you continue on therapy. There's a lot of drugs you don't really need to check levels on as long as the patient's responding well. So for instance, many antibiotics we actually don't check levels on. You just monitor the patient, see if they get better. You know, if they come in and they're having pneumonia and their chest x-ray is getting better, their fever is going down, their white counts are going down, everything's heading in the right direction, you're good to go. You don't have to worry about it, right? The other situation could be is that you see that the patient is either subtherapeutic, so for instance, if you have pneumonia and you're not getting any better, your chest x-ray is getting worse, or potentially the patient's developing some sort of toxicity, then you have to go back and kind of reassess. So at this point, we obviously cannot change things like clearance of the patient. We can't really change the volume distribution for the patient, but what we can do is monitor and correct the dose and or the interval. So again, either changing how much we're actually giving or how frequently or infrequently we're going to be administering that drug. So the reasons we use drug concentrations, they provide an additional amount of information that can be used in conjunction with some of our other clinical data to help in kind of determining what the patient's status is, right? So there's some patients, especially if you're looking at drugs like antiepileptics, right? So drugs for treating seizures. In a lot of cases, it's hard to say, like, you know, yeah, I could be on antiepileptic right now. I have no seizures. I never had a seizure to begin with, right? So it's hard to tell how effective the drug might be because in some of those patients, it may not have had a seizure anyway. So that's why you always have to take things into account with other patient factors there. So you're looking for toxicities, you're looking for efficacy, you know, all of which, you know, meaning just don't treat the number for a drug level. You want to make sure you're treating the patient. But by getting some of this drug information, when that's useful, we're going to be able to individualize that dosage regimen for that particular patient. And so we can determine as well, using these levels, have there been a change in any of the pharmacokinetics that have occurred during treatment? So for instance, if you have a patient who, say, started out with a pneumonia and now they're developing kind of a secondary kind of septic looking picture, you know, that can have pretty significant physiologic changes. You know, and now their renal function's gone down or now their hepatic function's taking a hit. So that could be one thing that can make us, you know, check drug levels to alter our dosage regimen. Or we could be looking for things like drug, food, herbal interactions that could be affecting the drug level as well, either increasing it or decreasing it, and you know, depending on the type of interaction we're dealing with. And also, sometimes you're actually going to be monitoring for adherence, right? So adherence is just what? Are they actually taking the drug or not, right? And so I remember I was talking to someone who's one of my fellow students at the time who's rotating in a pain management clinic, and they were like, yeah, we check for levels of hydrocodone. Hydrocodone's found in like Lortab and Norco, very common medication we use for pain management. And they're like, yeah, we check drug levels for hydrocodone for these patients. And they're like, well, why would you need, like, if you're prescribing it for them for pain, like, why would you need to check a level to make sure it's actually there? Why do you guys think you would need to? Yeah, so make sure that you're prescribing to them, they're actually taking it, because in a lot of cases you'd find that they would either sell it off for whatever their actual drug du jour was, whether it be cocaine or heroin or whatever they liked. And I'll never forget my wife, she did her second-year residency in pain management at the VA, and so part of her job was, you know, working out in the outpatient clinic, you know, dealing with these vets and stuff. And she remembers that she had this one guy who would come in, this little kind of hover around scooter thing. I think he only had like one leg, but he always had this most beautiful, decked-out girl on his lap, riding into the pain management clinic every single week. And all of a sudden they decided they wanted to switch his med over to something that must have been not quite so profitable, because all of a sudden he kept coming back, but the girl was not there anymore. So it was an interesting relationship. But anyway, So again, you can check for adherence by doing things like actually checking the levels to make sure that the drug is present when it's supposed to be. So anyway, some other things we could do if we suspect toxicity is related to having super therapeutic concentrations of drug, we can check there. If we're seeing a lack of therapeutic response, we're like, well, the patient should be getting better on this dose. Why are they not? You can look to see if the level's too low in those cases. Mention adherence. We can assess for changes in drug therapy. So if we had a level that was done that was too low, and then we alter the patient's drug regimen, then we can go back later, and once they're back at a new steady state, we'll go back and actually check to make sure that they are now within the right range. So it's done pretty commonly. Changes in clinical status of the patient, and then potential drug interactions. So these are kind of the most common reasons why you would go ahead and request drug concentrations. Again, it's not just because like, well, I just want to check, I just want to know what it is. That's not really going to be a good reason, right? Because we're going to see that's going to lead to either unnecessary changes in the regimen, or you're going to find that it's going to be pretty costly in the long run. So some information that you need to have to make sure you're interpreting serum drug concentration, because this is a big area for pitfalls where people will look at a level and they'll just kind of make a off-the-hip kind of assessment about it without really taking into account all the pertinent information. So one, you want to know what time the actual blood sample is taken. Okay, that's really, you might think that is pretty easy to get, but it could be more difficult than you might imagine. The nurse has to make sure she's documenting things appropriately, making sure she's actually going and getting the level when you prescribed her to do so. You need to know when the last dose was given. So again, getting that information between when the dose was given to when the actual level was taken. Know how the patient should be taking it. Knowing patient demographics, looking at their other concurrent medications they're taking, and then also you need to know the reason why you're monitoring for this. Why am I taking a drug level? In a lot of cases, people request a drug level, and I ask them like, well, is this actually going to change anything? Like, if it comes back, the patient's doing well, and you're requesting a drug level, it comes back a little too low, are you going to change your regimen? No. It comes back a little too high, you're going to change your regimen. Patient's not having toxicity. They're like, well, no. Then why are you checking the level, right? So you need to have kind of a rational reason for why you're doing that. And then also, you need to know what the desired pharmacokinetic or therapeutic range is going to be for these drugs. And so for some of these drugs, they have a narrow therapeutic index, so it'll be well published. We'll know exactly what kind of ranges we're shooting for, versus there's lots of drugs that you may, some of our docs want to check a level on. It's like, well, you can get a level back, but it really doesn't tell you anything because we don't know what the actual established level should be. And so a lot of drugs just don't have established levels because we really don't do a lot of that, the therapeutic drug monitoring for it. But also, certain drugs will have different indications that require different ranges. So a good example of this is vancomycin. You guys ever heard of that drug before? Yeah, it's used for MRSA or methicillin-resistant Staph aureus, so it's a very, very good gram-positive killer. And so we use it very frequently when we're using kind of broad antibiotic coverage. So, a patient comes in with really rocking pneumonia or they're septic. When we don't know what they're infected with, we'll give them vancomycin to kill off all the gram-positive bacteria. But essentially, depending on the type of infection you think they have, they may shoot for a different range because you learn that vancomycin has, it's a very large molecule and it has problems penetrating hard to reach areas, right? So for instance, if I have an infection in the brain, if I have meningitis, like that's very hard to get into because the brain likes to keep stuff out of it, right? The blood-brain barrier can be difficult to cross. The lungs can be difficult for vancomycin to penetrate. So in that case, what we'll do is we'll shoot for different ranges. So for say something like the bloodstream infection, it's very easy for vancomycin to get into the blood because that's where you're injecting it. So you may shoot for a range of say 10 to 15 mics per ml, right? That's the kind of range you're shooting for. Versus for something like a pneumonia, I'll shoot for 15 to 20, or meningitis, I'll do 15 to 20 to make sure I'm getting up high enough levels to penetrate those tissues, right? And again, we can't really directly measure the level of vancomycin at the site of infection, but we can get a good surrogate by having the blood level being drawn there. Okay, so again, common drug characteristics you're going to see in some of these, there's going to be kind of no clearly observable therapeutic or toxic endpoint, meaning that it can be kind of a range for a lot of drugs, which is why we don't have good establishment for drug levels for every single drug that's out there, and why we don't do a lot of levels for many drugs. But again, the concentration should be a surrogate for the concentration at the site of action. So in that case, in vancomycin, if I get a level of 15 to 20, I can be pretty well assured that the drug levels are getting high enough in the in the meninges in order to kill off the bacteria to get rid of that infection. And again, we're going to be doing this for narrow therapeutic index drugs, and usually they're going to have pretty variable pharmacokinetics. So especially these drugs are very highly dependent on renal elimination, or if they have they're very hydrophilic, and so you can have large changes in volume distribution based on kind of the fluid status of the patient. These are going to be things that are going to be more likely to do levels for to make sure we're actually getting in the right range. Okay. Also for these drugs, there should be some risk associated either with the toxicity. So if the levels get too high, if it's a drug that's so benign that if I get levels too high, there's no downside to it. It's not. I don't really care. I don't care what the level is. So it needs to be something that has some kind of appreciable toxicity. So for vancomycin, those levels get too high and they ride up too high for too long. You can see ototoxicity, and now all of a sudden they have hearing issues, right? Or they can have nephrotoxicity and have a decrease in kidney function. And on the flip side of that, there should be lack of response. Could also be pretty dangerous as well. So for in the instance of meningitis, if I don't clear that infection by getting my vancomycin levels up high enough, that could be pretty bad for the patient, right? It could lead to seizures, could lead to death. We don't want that to happen. So, and then we should see some stable pharmacologic effect as long as we're kind of maintaining ourselves within that therapeutic range. So, the drug assay that we use should be accurate, should be pretty precise. Should be pretty specific for the actual drug we're looking for. That's important for some things. You may actually have like cross-reactivity between different certain assays, but most of the time we're going to find for these drugs they're going to have very specific. They should come back in a reasonable turnaround time. So what do I mean by turnaround time? Yeah, so how long it takes for that to process the level for it to come back. And so, for instance, back in the day when we had iron overdoses, right, we didn't really have a good way to measure iron levels to determine if the patient could have been potentially toxic. So you'd have to like send off a level, but it'd go over to like Mayo Clinic or somewhere, or go outside of the hospital, and it would take days and days to come back. Well, by the time that level comes back, my patient's either dead or alive, so not super useful for me, right? And so instead, nowadays we can get better access to some of these levels. So I can do an iron level in any hospital and it'll come back within a reasonable amount of time. Another good example is like cyanide. If someone you have suspecting cyanide poisoning on, those levels take several days to come back. Again, my patient will either be dead or alive at that point. So you need some kind of reasonable turnaround time. And hopefully it will be relatively inexpensive. You're going to find that especially things that are send-outs or things you cannot do in-house tend to be a little bit more expensive. So some of the drugs that we commonly do therapeutic drug monitoring on be things like vancomycin, the aminoglycosides. So those are very good gram-negative killers. So it's very not uncommon you'd have a patient on vancomycin and something like gentamicin at the same time, especially when you're, we haven't talked about too much in antibiotics, but we're talking about empiric coverage for an infection. You guys know what empiric coverage means? Basically covers any and everything, right? So if you say, hey, my patient has pneumonia, here are the bugs that I think are most likely to have caused this. I don't know which one it is specifically, but I'm going to cover a wide range of things. That's when you can use multiple antibiotics at one time, right? So we're kind of using the shotgun approach and just trying to get everything before we can kind of narrow it down and go to a little bit more something specific. So aminoglycosides are a big one here because they kill a lot of gram-negative bugs. Cardiovascular drugs, so digoxin is a very good example of this, where we would do levels on to make sure they don't get too high or too low. And then antiepileptics are another very common one, so things like phenytoin, Dilanza, the brand name for that, carbamazepine, valproic acid. You'll see a couple of these, especially like carbamazepine and valproic acid. Nowadays we see them used a lot more frequently for bipolar disorder. They kind of act as mood stabilizers. So you may see patients on these drugs and they don't actually have any seizure disorders. That could be one thing you end up running into. And then also some immunosuppressives. So things like tacrolimus we'll see used post-transplant in order to prevent things like graft versus host disease, where the body will reject a transplanted organ, or if they have some sort of like autoimmune condition where they're really kind of in a pro-inflammatory state, we might try to tamp that down by using drugs like tacrolimus. And of course, what would be the risk if I had too much of an immunosuppressant around? Yeah, they get secondary infections, and so you really worry about viral bacterial infections in the cases. So that would be a good reason why you want to keep that in a good range, because if they get too immunosuppressed, yeah, they're not going to reject that organ, but they're also going to end up getting a nasty fungal infection and then die from that, right? So again, some of the limitations with doing this TDM is going to be costs. Oftentimes it's going to be more expensive. In a lot of cases, though, you'll find, especially when they did some studies looking at kind of doing prospective therapeutic drug monitoring and prospective drug dosing, you'll find that it actually saves money, right? And so why do you think that would be? Well, if I can prevent toxicity, if I can prevent us having to treat an issue of, say, getting a secondary infection, or if I can, prevent us from having ototoxicity, where now the patient has to be managed for that as well, that can be cost saving, right? Or if we're also making sure we're getting up to therapeutic levels, so that way the patient clears the infection faster, they are now out of the hospital sooner, you can get another patient in there to make some more money off of that, right? So again, you can actually find cost savings by doing this in the long run. If a drug has a wide therapeutic index, this isn't going to be super useful for us because, again, it doesn't really matter because you'd have to get such a high level to get toxicity that it doesn't really get get a lot of use out of that. So it needs to have a narrow therapeutic index. And then, again, a lot of drugs you can get levels on, but if we don't know the relationship between concentration and response, that hasn't been established, and the level's not really useful, or if there's not any kind of reference data that's available. And then again, if we have a direct response measure, kind of looking at things like, if we're giving someone warfarin, we don't measure warfarin levels, we measure the PTINR, because that's the direct effect that it has on the bloodstream. Those are going to be a much easier tests to get back than looking at a warfarin level. Okay, so those are kind of the limitations there. Okay, so some inappropriate uses for drug concentration. So if we obtain levels too routinely or too often, that can be problematic. It can especially be an issue if you're thinking about really some of our neonatal patients, especially because, again, their blood volume is pretty low, and you still need a decent amount of blood in order to run some of these assays. So you can actually end up causing anemia in some patients if you're taking blood too often. Do we need a concentration of the patient's responding appropriately? You may not need that in a lot of cases, right? Some drugs you will get levels anyway because, again, the toxicity may not manifest for a while, but in some cases, if the patient's responding well, you may not need a level. They're obtained for patients when no apparent change in patient-specific kinetics occur, right? So a lot of times when we're dosing things like vancomycin or aminoglycosides, we will start a patient on a dose, we'll get a level, get them to a therapeutic range, and at that point, we probably don't need to check a level for a while, right? As long as they don't have any acute changes in renal function, hepatic function, we may check a level, say, once every couple weeks or so, just to make sure they're still staying about the same. Don't want to do this too early. And then samples taken at the incorrect times. So we'll look at some issues with that. But, if you're looking for a trough level of a drug, but the nurse takes it right after they give the dose, what's that going to be measuring? It's not a trough at that point. It's going to be peak level, right? So again, then all of a sudden we would be assessing that, we say, well, this level is way too high. We got to do something about this. And really, you just see that the nurse had given the drug, and then they check the level, right? So nursing education can be really important on this to make sure they understand why they're doing levels at certain times versus giving the drugs. And as long as they understand that relationship, you're much more likely to get correct information. So again, therapeutic drug monitoring has been shown to reduce the number of patients encountering toxicity, which is a good thing. When more patients are going to have drug concentrations within that therapeutic range, so hopefully they're getting more efficacy out of that. And of course, this is going to be compared with patients who are just kind of dosed with kind of standard doses and never kind of followed up on. So it's kind of the benefits we have here. So potential benefits here, you can see improved effectiveness of your drugs, reduced toxicity, hopefully decreased length of stay, which again, in a lot of cases when a patient comes into a hospital for, say, pneumonia, based on their diagnosis code, the hospital gets reimbursed so much money for that, right? And so if the patient takes, 3 months to treat versus just 1 month, or 1 week, they still only get the same amount of money. So the hospital's incentive is to get patients better, get them out of the house so that way they can bring someone else in and get new money for that. So you can see some decreased length of stay. It's better for the patient as well if they're not in the hospital. I would say the worst place to actually get better is the hospital because, again, it's a very nasty place. There's lots of other bugs kind of floating around, other infections and things can happen. So you really want to get them out as soon as you can. And then, again, we're going to hopefully have more rational use of these drug concentrations, not just measuring levels kind of willy-nilly. And it can be very cost-effective if you're doing this kind of prospectively. So some of the drugs we mentioned that we have found to be beneficial, things like aminoglycosides, probably are, this and vancomycin, especially from the pharmacy standpoint, because you'll see in a lot of hospitals that you'll have a pharmacist-driven protocol where basically you'll write for a consult for aminoglycoside or vancomycin, and then basically the pharmacy department will actually end up taking over, where their clinical pharmacist will come in and make assessments. They'll come back to you and say, hey, this is what I want to do. You'll say, hey, that sounds good with me, and then they'll go ahead and write the orders and then do the levels and all of that. So you basically don't have to really think about it. But in the off chance that you're in a place where they don't have pharmacy services there 24/7, you might be the one doing this, okay? But so those are probably our bread and butter. Theophylline is a kind of an old school asthmatic drug we don't really use too often. Digoxin we'll certainly do on occasion. Lithium we'll use for like bipolar disorder. This one is because it has a very narrow therapeutic index, and because bipolar patients are by nature kind of prone to either not taking their drug or taking way too much of it. This is why we check levels for them. And then certain other antiarrhythmics like procainamide, some old school drugs. So the steps that we would take in doing therapeutic drug monitoring for these patients. So one, routine monitoring or specific indication. We need to figure out if this is something that we absolutely need to get a level on or not, if we have some sort of compelling indication to do so. So again, looking for things like they're having a lack of response, the patient's just not getting better despite getting a therapeutic dose, what we think is therapeutic, or if they're having some sort of side effect at a therapeutic dose. So maybe the patient has some kind of altered kinetics, maybe they're just not metabolizing the drug correctly, they're having some degree of side effects. Let's go ahead and try to check a level, see where they're at. Looking at the blood sample collection, is it the right time? Is it the right actual collection tube? There are certain tubes that will be affecting different lab tests, right? So there are certain tubes that actually are lithiated, which means they contain a high amount of lithium in them already to begin with. So if you check a lithium level in a lithiated tube, guess what your level is going to come back at? Mega high, right? And you're like, well, the patient looks fine. What's wrong with this? Okay, well, probably because these are wrong tube. There are certain tubes that have heparin in them to try to keep blood from clotting. That can affect clotting assays. So again, make sure that the nurses are educated. They know the right tubes to use. And then obviously the timing of this is going to be critical depending on what kind of levels we're looking for. Then we'll get the laboratory measurements. We'll come back and then we'll be able to incorporate that information along with when we know when the dose was given, when the levels were done, and be able to make some sort of assessment. Also, be really careful with what kind of units you're dealing with, because if you get the units wrong, you can make kind of some poor assessments. So I'll give you an example of this. Consulting at the Poison Center, we get calls from basically, I still take call for the Jacksonville Poison Center. We basically cover all through the Panhandle to like just above north of Orlando. And so we get a lot of different hospitals, and they all have different labs, right? So they may have different reporting out of different things. And so, for instance, an aspirin overdose, a therapeutic level of aspirin would say between like 15 and 30 milligrams per deciliter. Okay. So, all right, 15 to 30, and then when they start to get like 80, 90, 100, that's when I'm really concerned about that patient, right? They're really at risk for having huge metabolic acidosis and having seizures and all kinds of bad problems. 100 milligrams per deciliter. So I was talking to talking with the doc, and they said, oh, well, the level came back at 400. And I'm like, well, is the patient dead? And they're like, no, the patient's not actually doing that bad. And I'm like, well, hold on, this doesn't make sense. What units were the actual levels done in? They're like, oh, it's micrograms per ml. I was like, okay, this makes more sense. When you convert the micrograms per ml, that 400 turns into 40. Now it's not really that super therapeutic. That makes sense why the patient really wouldn't be that symptomatic. Okay, so be really careful with your values to make sure you're interpreting them correctly.
Is there any disadvantage to having to wait for the lab result before you give the next dose?
Yeah, in a lot of cases, as long as there is no, and that's actually a really good question. So a lot of times people say, well, we want to wait for the level to come back before we give the next dose, but especially for drugs like vancomycin, we'll learn that for certain antibiotics, it's really, really important that they stay above the minimum inhibitory concentration for that bacteria, right? So there's a minimum level you need to stay above to make sure you keep that bacteria from growing. So for a drug like vancomycin, you're say giving it every 8 hours, every 6 hours. You want to make sure that the troughs for that drug stay above that level. Because if you dip down below that, now all of a sudden bacteria start growing again, you're hitting some problems with potential resistance and failure of therapy. So we have to educate people on that. We say, no, go ahead and give the drug, give the next dose. So that way you make sure that as long as it comes back therapeutic, you're fine, right? If it comes back a little out of range, it's okay. We can deal with that. Okay, it's unlikely, especially for a drug like vancomycin, for it to be like kind of a life or death kind of situation if the level is a little too high or a little too low. We can correct for that. Certain drugs though, you may want to wait for the level, but in most cases you just keep giving the drug. As long as they're not manifesting, like, as long as they're not seizing or something from it, like, that case you probably want to hold it. But in a lot of cases, you would still just continue giving it.
And you've just adjusted the next time.
Yeah, so we adjusted for the next dose. Yeah, so that's actually a big thing because we would have a lot of nurses who were very hesitant about giving the next dose of a drug before having the levels back. Because they're like, well, what if? And it's like, well, you have to do the risk-benefit analysis. The risk of them having their infection getting worse is pretty big if they don't get the drug, versus the risk of them manifesting maybe some toxicity down the road is pretty low. So let's go ahead and just give it. And so for that situation, that works. Versus some other ones where there may there's always a lot of gray. Maybe some situation where you want to hold it, but in general, we just go ahead and give it. Yep. There's not always going to be one right answer, so I know it's a frustrating part of medicine, but you guys will get used to that over time. Anywho. Okay, so then once we have our levels back, we will look at the therapeutic management. We'll take the clinical picture into account. And again, if the patient, if our level is 15 to 20, the level comes back at 21. Patient looks like they're getting better, they're doing well, they're not having any toxicity. Do I need to mess with that? Probably not, right? So if they're a little bit out of the range, because again, when you're looking, and we'll talk about this in biostats, but when you're looking at a reference range, you're kind of talking about 2 standard deviations from the norm, right? So you're looking at basically 95% of the population. You're still going to have 1 in 20 that are going to fall outside of that. So it's okay if you're a little outside the range, as long as the patient's responding, as long as they're not toxic, you can deal with that. But if it is truly out of range, we can go and optimize our drug treatment, either modify the dose or we're going to modify the interval. Sometimes we'll do both, but usually it's one or the other. And then we rinse and repeat. You'll go ahead and wait till the drug, dose it until it gets to steady state again, and then go ahead and reassess at that point. Okay. So why is it important to wait until the drug gets to steady state before you check a level? Would it be falsely low, falsely high? Yeah, it would be falsely low. So that would be one of those cases where if we're checking it before it actually comes to steady state, you'd end up checking it a little too low. Because remember how you saw those graphs where you give intermittent doses and gets higher, 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 and eventually gets to that steady state where you're metabolizing what you're putting into the system essentially. So if you check that too early, then you end up making assessments on that drug, and you normally end up upping the dose too early, and then that way when you actually get the new steady state level, the patient's going to come back super therapeutic, and that's no good. So that's why another thing is really important to know when the steady state is going to be reached, so you know when to check that level. So a good example is vancomycin. That one has a fairly short half-life, so if I'm dosing a kid, say every 6 hours of that, I know I can check a level before the 3rd dose, or 3rd or 4th dose, and they are pretty well assured to be a steady state at that point, right? Versus some drugs I may need to wait a lot longer than that before they actually get to the steady state. So we'll look at some examples of those as we go on. So again, considering pharmacogenetics and therapeutic drug monitoring. So therapeutic drug monitoring is in general reactive, right? So we'll try to prospectively assess the patient, give them a dose and a regimen, and then when the levels come back, then we react to that and we say, okay, we're going to change this, go from 500 to 400 milligrams every 8 hours, whatever it happens to be. Knowing some pharmacogenetics on the patient beforehand could help us to be more proactive and individualized. So this is something you might see more in the future, especially as you guys are practicing for the next 10, 20, 30 years. And so hopefully we can have be at a case where we can have pharmacogenetic guided therapeutic drug monitoring. So based on the presence of certain mutations, we can say, okay, well, this patient is going to be an ultra rapid metabolizer. We want to up the dose of this drug or give it more frequently. Or if this person's not going to metabolize it very well, let's give them a smaller dose or less frequent dosing. So that may be something you'll see kind of in the future. We already had this for some drugs, so like certain patients, and this is more for things like warfarin, so people can have mutations in like CYP2C9 or 2C19 that leads them to not be able to metabolize it as well. So we already know for them, if you were to do that test on that patient, that you would kind of go ahead and start them at a lower dose. But the problem is that a lot of these are very expensive, and it's hard to identify which patients are going to be most likely to get some benefit from that additional testing. You had a question? All right, cool. Or was I going to answer the question before it was asked? That's what I try to do. So again, if you're looking at kind of a homogeneous group of patients, you can see that, okay, well, the majority of people are probably going to have a pretty good predicted response to the tested drug. And again, when we're looking at therapeutic levels, this is based on studies where we're looking at a group of patients who receive the drug and what kind of levels they receive the most benefit at without having toxicity. If they only looked at 100 patients, and that's what we use to base it for every patient we treat, there's going to be some outliers there, right? You can have people who are predicted a poor response based on pharmacogenetic differences, or those that are more likely to have toxicity based on decreased metabolism of the drug or whatever it happens to be. So this would be the benefit of if we get better and cheaper and more available genetic testing, is to figure out like, okay, who's most at risk for responding well to this drug versus not responding very well. Okay, and again, you could see, instead of for nowadays, kind of the idea is you start with one drug and see if this works, and then you may go to this drug and this drug, and then okay, drug C didn't really work. Let's go try back and try a different dose of drug D. Hopefully, when we get better pharmacogenetic kind of type of testing, we can say, okay, well, you know what, we don't want to use any of these drugs. These are not going to be good. Let's just go straight to drug D at this dose, and it can be a lot more prospective. So hopefully, that'll be the things that we move to in the future. Okay, so let's do an example. Let's look at a digoxin case. We mentioned digoxin is a antiarrhythmic. We use a lot patients with either AFib or it will be used for patients with congestive heart failure. It kind of helps with contractility of the heart. It helps to get a little bit better squeeze, because you'll find that those patients they have kind of a weaker or stiffer left ventricle, and so we like to increase that squeeze in the heart to increase cardiac output. So that's something we like to do for these guys, and digoxin helps with that. So for instance, let's say we have a patient who's been on the same digoxin dose for 15 days. And is seen in the clinic and is found to be doing pretty well clinically. We do a digoxin plasma concentration. We do it the morning of the visit, and it is reported back at 3.4 nanograms per ml. Okay, therapeutic range is 0.5 to 2 nanograms per ml. So based on this, what is your assessment so far? Too high of a level, right? So you're like, okay, this level looks too high. But then what's your other assessment of the patient? She's doing well, right? She's not having any problems. And so some of the things you can see, and I'll never forget, I was actually in pharmacy school probably like my first year, and I was up in Jacksonville, and I was at the YMCA at the time, and I'll never forget this. The YMCA, like, there's a lot of old dudes walking around. They have very little shame. So most of these men gentlemen were naked in the locker room. But I'll never forget this one guy was talking to another old guy. He's like, yeah, I'm starting to, everything's got the lights have these halos around it, and everything's looking kind of yellow. And I didn't know it at the time, but afterwards I was like, holy crap, that guy had too high of a digoxin level. Like, he was very classic, like, GI upset and seeing these halos, and if you have yellowing of lights, that's called xanthopsia. So I was like, man, I wish I told that guy something, but of course, when you're a first-year pharm student, you don't know anything. So I'm like, you guys really don't know anything at this point. You can diagnose, well, maybe you probably diagnose like an MI or something, right? But chest pain, you probably should go to the hospital, that sort of thing. But at this point, I was just like, oh, that's weird. The guy sees yellow lights. Anyway, I was more concerned with his nakedness at the time. So anywho, so what could be some possible reasons why this patient would have a high level? They just took it? Oh, interesting. Okay, so maybe we're checking a level too soon. Could be one possible reason. What else?
They've taken it too early, like compared to their previous dose.
Yeah, so maybe they're taking it too frequently. So maybe we tell them, certain drugs will say take at nighttime, and maybe she took it at night and then that next morning. So the doses were stacked too soon. It could be one thing. What else? Yep, so we're giving too much drug to her. What else? Yeah, so renal function. So we'll find that renal function is really important for digoxin clearance. So maybe if that had changed at some point, or maybe we had not assessed what the renal function was before we dosed her with digoxin, that could be one reason. Certain other drugs, hepatic function will be important for that. Right, so those are all good reasons why her level could be too high. Consider the fact that it's either going to be what we're putting into the system or what we're not getting out of the system. It could lead to a high level in this case, okay? Good thoughts at first. So again, the next question is to ask, okay, when was the dose last taken? We do this very frequently. We have a lot of older patients who are in nursing homes, and sometimes those patients don't get really monitored all that well, and so they will end up, they'll get all their doses of drug, but no one's really kind of monitoring for them, like what's their fluid intake, like are they getting dehydrated, and so we'll have these patients who will come in with high digoxin levels. We have to say, like, okay, when was the last time you took a dose, right? Because it helps us to make an assessment. If it had been 2 days ago and their level is still super high, then I know that's a problem, right? Versus if they'd just taken it, that may not be as big of a problem. You want to know when the blood was drawn. So in this case, we'd ask the lady, and she said, oh, I took my last dose this morning. And we say, okay, well, she took, drew the blood, say 9 o'clock this morning as well. Ask her what her regimen is. Make sure that what we prescribe to her is going to be the same thing that she understands that she's supposed to take it, right? So if you're saying take one pill every single day, make sure she's actually doing that and being adherent to that. And then again, looking for adverse reactions. So again, yellowing of the vision, that halos around the lights, nausea, vomiting, those can all be pretty indicative signs of some sort of digoxin toxicity. Also, she's feeling any kind of like palpitations. Digoxin is kind of interesting because you can either see tachyarrhythmias or bradyarrhythmias. So again, if you check her pulse and it's 40, that's probably not normal for her. So maybe you should so there's other things you can kind of be assessing for. So if she's having kind of poor cardiac output, maybe her exercise intolerance is getting worse. Different things you can kind of be assessing for. But she said, no, I'm totally fine and everything feels good so far. So again, looking at our average steady state concentration, remember that we're looking at bioavailability. It's going to be multiplied by the dose. So again, these are, we can't really affect bioavailability unless there's some sort of drug interaction or food interaction we're not aware of. The dose we can fix, and then obviously the patient is going to be dependent on determining the clearance, and then we can also assess what that dosing interval is going to be. So again, we really have control of these two intervals. Bioavailability and clearance we may not have as much control over. So looking at bioavailability, is the patient absorbing more than what we would expect? This is usually not the case. Usually you're going to find if you have low levels that there's some issue with bioavailability. Either maybe they have ramped up CYP enzymes that are metabolizing the drug before it can really get to the systemic circulation, or maybe there's some other issue going on there. And then looking at the dose, is the patient taking too much, right? That's kind of the question, is she misunderstanding the instructions and she got it mixed up and she's taking her digoxin twice a day and her metoprolol once a day, little things like that they can get kind of confused, especially as, memory impairment happens, they don't have good care, things like that. So looking at the clearance, has the patient's clearance changed recently? So do we have a baseline renal function that we can look at to compare to what's happening right now? A lot of cases you may not have that information, which is less useful, but for some of these people who you'll be seeing over the course of months to years, you'll hopefully have some of this information to kind of make some baseline assessments. That's why I always ask, if we're dealing with patients who we're assessing from like a tox standpoint, we always say like, okay, well, they're having these EKG changes. Like, well, what's their baseline EKG? Hopefully we've had one, so if he came in for chest pain, 6 months ago, and now he's coming in for an overdose of whatever, we can make some comparisons there, right? Same thing for renal function, hepatic function. You're looking for trends over time to see if there's now a new difference. And then looking at the dosing interval, again, more frequently, bigger dose, whatever happens to be, we can see, hopefully she's going to be taking this just as we prescribed it. Some other things you consider, is there an assay error? Was there some issue to where maybe there's a cross-reacting substance, maybe is goofing up your level, or maybe the lab ran it incorrectly? It's not to say that every lab value that comes back is going to be perfect, because there could be some mix-ups, right? They, maybe they switched it with someone else's lab value, right? So maybe they actually got, if the level came back as 0, and the lady's like, I swear I'm taking it, maybe it got mixed up with someone else, so always consider the lab error. Certain interfering substances. So kind of not germane to this discussion, but there's certain plants out there that actually contain products that look just like digoxin. So if you were to ingest like an oleander or a lily of the valley or something like that, if a dog or a kid got into it, that actually will cross-react with digoxin, even though the chemicals are a little different. They look similar enough to those assays where they'll both cross-react. So there could be some issues there, but that's a pretty rare occasion. So now what do we want to do? Okay, we want to confirm our sample timing, make sure that we know what time the drug was or what time the level was taken, determine the patient adherence. Hopefully she's telling us the truth. Usually digoxin, I don't imagine she'd be lying to us unless she was taking it less frequently and didn't want to own up to it. Sometimes patients are pretty cheap and they'll be like, I can't really afford this every month. I can do it every other month. Let me just take one every other day. Maybe that'll work, right? Assess for concomitant substances. Maybe there are drugs that are inhibiting metabolism that could be interfering here. Again, you always want to not just ask, like, what medications are you taking? Because patients may not always assume the things they're taking could be considered medications, right? So herbal supplements, are they taking anything that could be affecting that? Drugs that you can get without a prescription, things like that to try jog their memory to have them be more complete in their history. In some cases, you may want to repeat a level. That's oftentimes what I'll tell people when they get a level that comes back and it just doesn't make sense. I'm like, we'll just repeat it. Make sure that it's consistent with what the last one was. Sometimes that can be useful for helping us out to decide, okay, well, that first one's probably erroneous, and maybe this one is not going to be more accurate. And then, of course, we can look at the bioavailability and clearance. So again, assess the patient's renal function in this case. Look to see if there's any kind of drug-food interactions or anything like that that could be affecting the bioavailability as well. Again, so does this drug fit the indications for doing therapeutic drug monitoring? So again, looking for explicit criteria. Do we have an adequate indication? Yeah, I think so. Digoxin is an aerotherapeutic index drug. It's going to have, when you're starting a patient out on a new regimen, like this is typically one of those drugs you want to check the level for to make sure they're not going to develop toxicity, make sure they're going to get enough drug in the system to actually be effective. We want to make sure we're having the appropriate timing, and then we have this rational interpretation. So we don't just say, the level's too high, let's reduce your dose. We always want to ask the question, well, why is the level too high? Okay, or why is the level too low? And go back and assess that before you make any decisions in changing that regimen. Okay, so again, adequate indications for digoxin if we suspect a toxicity or an adverse drug reaction, that would be one indication. Again, newly initiating treatment would be another good one for in this case. Or if we had a recent dosage adjustment in patients like renal instability, so if we changed the dose recently in response to a bump in their serum creatinine, then we can go ahead and reassess that level afterwards once they've hit a new steady state to make sure they're clearing it okay. And then just high-risk patients. Some of those patients are just going to be so fragile from, say, a cardiac standpoint or hemodynamic standpoint. You want to just to be sure, you can go ahead and check levels on those patients as well. Okay. Other things, drug interactions. If you have a new drug interaction that could be affecting digoxin clearance or something, you can check a level for that. If you're suspecting overdose, and again, not necessarily intentional overdose, but they could just have been overdosed chronically over a period of time and not even realize it. Changes in pharmacokinetics, and mostly clearance is the thing we'll be focusing on there. And then again, if we're trying to make a decision for future therapy. So, for instance, if you were having a patient who's like, their AFib is still really uncontrolled, and even though they have therapeutic levels, they may decide, okay, well, maybe this drug's not right for you, and we'll go over to something else. That could be another indication. Okay, so again, when we're interpreting these drug concentrations, effects you need to be aware of. Okay, is the drug at steady state? We already kind of mentioned this, but if you check before the steady state level, chances are you're going to have a level that looks falsely low, and that could lead you to up the dose or up the interval too, kind of prematurely, which could lead to toxicity. So we don't want to do that. You want to make sure the sample timing is correct. Because again, if you're expecting to have a peak level and the nurse is checking it, say 6 hours after the last dose, that's not going to be a peak level. Or if they were to check a trough level right after they gave a dose, that's not going to be correct, right? So we want to look at the adherence, make sure the patient is taking the drug as prescribed. Timing of the dose and the sample collection needs to make sure that makes sense. For some drugs, you'll find that we'll do random levels. But in a lot of cases, we're either looking for specific peaks or troughs, and again, when you're looking at your drug references, they'll kind of tell you what levels those correspond to. So for something like vancomycin, where it's really important that we keep above that minimum inhibitory concentration for the bacteria, we check trough levels, right? We don't really care what the peak level is so much, because as long as the trough is getting down far enough without getting too low, then we know that the patient is clearing it okay, and we know that they're still remaining effective. Versus something like gentamicin or something, we would also check peak levels because we want to make sure the level's high enough to kill those bacteria. We'll cover this in a lot more detail when we get to pharm, talk about bugs and drugs. Okay, have you guys heard anything about bugs and drugs in pharm? It's a little intense, so I'm going to try to get you guys, at least, I'm trying to make you guys start to think about this stuff a little bit now, so that way hopefully it won't be complete culture shock, but buckle up. Anywho, the blood sampling site can be really important, so looking to see where you're actually going to be measuring the level from can be really important. So especially for drugs that are administered IV. So imagine if you're giving a drug through an IV and the nurse says, okay, I'm going to go ahead and draw the level, and they pull it off of that line. What could happen? It could be really freaking high. So you get a level that comes back and it's like 400 or something, something crazy. And you're just like, okay, this is probably because the nurse accidentally drew it from the line, or if they did not flush lines appropriately, or things like that. So you always have to consider that. Usually for, in this case, for a patient's coming back to the clinic, you could just go ahead and do a random stick, and that's usually going to be sufficient. But for some other cases, you have to consider that. I remember, certain snake bites, you end up finding that patients have coagulopathy, where basically their clotting factors just kind of go crazy, and so we monitor for that over time. And so remember, we had a patient who had been bitten on the left arm, and the nurse was drawing blood out of that arm. And I was like, well, that's not really going to be super useful, because that's where the snake venom is probably causing a lot of local effects. Checking on the other arm, that gives you a better idea of what the systemic actual actions are going to be happening there. So again, always consider where the levels are drawn from in that case. And of course, there's going to be some inter-patient variation. Again, just because a patient falls outside of that range to some degree does not mean you need to go ahead and change the level or change the dose. Okay. So again, reasons why the drug administration or the blood sampling logistics might not make sense. So if we were giving the wrong dose, so that could be something where maybe the pharmacy made it incorrectly, or the patient is taking it incorrectly. The infusion rate could also be affecting this. If you're giving a drug, say certain drugs that you give over 30 minutes. And so you should expect some degree of a peak level after that, versus if you were to give it over 6 hours, you're not really going to see that same kind of peak, and that could be affecting your levels. If you were to skip a dose or hold an infusion, so we run into this, fortunately not too frequently, but say for instance you're in the hospital and the nurse is supposed to draw a level for a drug, and the level comes back undetectable. You're like, well, what the heck happened here? And they're like, oh, I accidentally hold that last dose because they had to go down for an MRI, and then they came back, and then we decided to go ahead. So you have to look at the logistics to see, was something held? Hopefully your documentation is good. If not, then that could lead you to trying to track down nurses who may have already gone home, and it's no good, right? So hopefully documentation is really good in this case. The drug was given at the wrong time, but we drew the blood at the right time, that could lead to erroneous levels. And if the drug was given at the right time, but the blood was drawn at the wrong time. So again, we have to make those kind of assessments based on when did the nurse say they drew the level versus when the nurse said they actually gave the drug. All right. Yeah, because sometimes you'll have nurses that will go ahead and just document, hey, I went ahead and gave the drug, because they don't like to have overdue stuff on their MAR. You guys know what a MAR is? It's a medication administration record. It's basically where they document. They have a list of all the drugs that are supposed to be given the patient, and they'll document off, check off when they have given the drugs. And so basically they'll be like, okay, I went ahead and gave that, and they'll go do something else, and then come back, oh, I forgot to hang that up, and so then they'll hang the drug, and now your documentation's off, right? So hopefully they're going to be pretty honest with that. But if you have issues where the drug is drawn from the administration line, that can lead to high levels. Samples taken from the wrong patient. It's not uncommon for us to, especially in the NICU, you'd have baby A and baby B right in the same room. One of them's on gentamicin, and we're trying to check levels, but you accidentally draw it from the wrong one. lead to problems, right? This is where patient barcoding can be really important. So they all have bracelets on that will have a barcode associated with them that is unique. So that can be very useful in helping to prevent errors like that. There could be issues with sample handling. If you're using the wrong collection tube, I mentioned those lithiated tubes or heparinated tubes. If the level has to be kept on ice, but it's kept at room temperature, things like that could all be affecting what the assay actually looks like. Okay, looking at factors related to the pharmacokinetics. So again, reasons why the levels may not make sense. Patient pharmacokinetics fall outside of the population average. Maybe they have some difference about their volume distribution or their clearance or whatever happens to be. Maybe they are extremely edematous, and that's causing the drug to have a different volume distribution now. If you draw a sample prior to steady state, that can also be affecting this. And then looking at the blood draw as being inappropriate time based on the drug pharmacokinetics. And so one of the things you'll see with certain drugs is they have what we call a distribution phase, which essentially means that you'll have a very high level to begin with, but it will drop pretty precipitously because the drug is partitioning it to whatever tissue it likes to go to. In the case of digoxin, it likes to go to the heart. It really likes to bind to the heart. So even though it looks like it has a very high volume distribution, it's only because the heart likes to bind up all that digoxin. Lithium does this as well, where you can have a distribution effect of lithium into the tissues because lithium, you guys know where lithium lies on the periodic table compared to something like sodium? Like next door neighbors. They're both kind of single charge cations there, and so they look very, very similar to one another. And so for some of those, it's very difficult for it to cross into the tissues. It can take time, and so again, you can have that post-distribution level. Or if you check it too early, the level would appear very high, but if you were to give it the appropriate amount of time, you check it again, it comes back normal. Okay. So other things, was the wrong drug being assayed? So accidentally ran a test for phenobarbital when your patient was actually on phenytoin, right? Of course, that level will come back negative because that's not what the patient's taking, right? Sometimes you have interference with endogenous substances. This is actually interesting. Patients who are very critically ill and very stressed, they can actually release certain products that will cross-react with the digoxin assay. So you get a level comes back and it's high, and you're just like, well, the patient looks like they're doing okay. What's going on with this? And then you can realize, oh, well, patient's super hypotensive and they're on all kinds of vasopressors and they're really stressed out. Physiologically, that could lead to those issues there. But this would not be our case in the patient we're just talking about. But improper or prolonged storage of the dose or the level could lead to assay errors, and then just technical errors. So if the test was run incorrectly, that could lead to problems. So, case resolution. So, the thing you have to realize with digoxin, it has a 6 to 8 hour distribution phase, which means if I check that level before the digoxin had time to partition onto the heart, the level is going to look too high. So, basically, if you were to go back and talk to the patient and say, well, I took my dose at 8 o'clock this morning, took the level at 9 o'clock, yeah, of course the level is going to look too high in that case. So, in this case, they took 2 hours prior to. They went ahead and repeated it at 6 hours and came back at 1.1. And we said that the level was between, the therapeutic range was 0.8 to 2. Patient's okay, guess what? We don't have to do anything. And that's always the best circumstance, is when you don't have to do anything. That's what I always tell people is like, just, if you have a choice to do something or not do something, just leave them alone. Just the best you can. It's usually the best thing for them. Okay. So in summary, therapeutic drug monitoring is we're using serum concentrations and applying those principles of pharmacokinetics and dynamics to individualize and optimize that patient regimen for that particular person. You really need to understand the merits, the limitations, and what are the appropriate applications of that in order to make sure you can interpret that serum concentration correctly. I can't tell you how many times our neurologist will request levels for these anti-epileptics, and I'm like, well, there's no therapeutic range. I just want to see what the level is. What are you going to do if the level comes back at, 4? Like, you don't know if that's therapeutic, you don't know if that's toxic, like you can't do anything with that. And so in those cases, in some cases they're trying to see just if the drug's even around to make sure the patient's actually taking it. Some cases they just want it for their comfort, right? And so it's always not going to be appropriate, and that's why you can help out and say, oh, well, maybe that's not a good indication, let's go ahead and save that money and not do that for that patient. Okay, so any questions on that? All right. We'll give you guys a 10-minute break. We'll come back and continue on with more pharm. All right, so this is the last section before we do the review, and then you guys will be all done with pharmacodynamics. We're kind of hitting the home stretch for this one. Yay! Okay, all right, so today we'll talk a little bit about designing treatment regimens and some miscellaneous topics we'll cover here. Okay, so we're going to look at rational prescribing. Hopefully you guys will all practice this. I've seen lots of irrational prescribing done in my days, and it's no good. So we like to keep things rational. basically, our therapeutic approaches, once we have a diagnosis, once you guys have figured out what the heck is wrong with the patient, oftentimes you're going to find that it could lead to things like surgery, radiation, it could be counseling. In a lot of cases, you may find no therapy is needed, but more often than not, you're going to find that medication is going to be utilized for this. So it's very rare that you have a patient gets admitted to the hospital that does not get put on some sort of medication, either one they were on beforehand or one that they're going to have started new in the hospital there. And again, most likely going to require a prescription for the most part. The kind of nature of the beast. So when it comes to, a patient comes to the visit, they come to you, they say, oh man, I got this chest cold. What do they want to leave with? A prescription. Yeah, they want to leave with something. They're going to feel gypped if they come to you and you go, you just have a virus. And you're like, yeah, but I kind of want a Z-Pack. And you're going to go, but you don't need a Z-Pack. You don't have a bacterial infection. Yeah, but just in case. This is unfortunate. This is irrational prescribing, so please don't do this. But usually like about 2/3 of the time they're going to get some sort of prescription out of this. Some people will not leave your office until they have got a prescription out of you, so it can be kind of intimidating sometimes. But an average 1 prescription medication per event, per visit. And so really when we're deciding to prescribe something, so we say that yes, you do have an adequate indication for a drug, we want to follow this kind of stepwise approach to determine what's the best drug for that patient. So first off, we want to make our specific diagnosis. Often the patient wants you to do something, but really you don't necessarily want to just write a prescription to satisfy the patient. Obviously you want good patient satisfaction, but it should not be contingent on getting a prescription every single time. So this can lead to things like unnecessary costs that patients are going to incur. Antimicrobial resistance is a huge issue. That's why drugs like, that comes in a Z-Pack, like azithromycin, losing effectiveness. Drugs like your fluoroquinolones like levofloxacin or ciprofloxacin, they're losing effectiveness because we're getting so many resistant bugs to this because we overprescribe it. Every patient comes in with a chest cold, here, take a prescription for Levaquin, and now all of a sudden people are getting inappropriately treated. We're selecting out for only the most hardy bugs, and then now we're running out of effective options to treat them. And then also just adverse drug reactions, right? So patient being subjected to unnecessary medications causing adverse drug reactions. So again, once we have our diagnosis, so we have to have we need to have some sort of tentative diagnosis. It may not be the actual final one, but at least some idea of what's going on for the patient. So again, say we have a patient who comes into our office, we think they have probable rheumatoid arthritis. You guys familiar with rheumatoid arthritis at all? It's an autoimmune condition essentially where body is not able to detect self from foreign products, and so it starts to attack the joints primarily. Some other problems that can come about from that. But basically, at this point, you're going to say, hey, this is what I think is going on. The reasoning should be shared with the patient. Again, it should be a good two-way bit of communication that happens between you to the patient. So next, you want to consider what the pathophysiology there, and of course you're going to learn much more about this in the upcoming years. Hopefully you guys have a very good physiology background that will allow you to make better sense of the pathophys. Hopefully your teacher was not too bad. So you need to have knowledge of the disorder. Positions, having that background positions you to make better decisions about what you need to, we can offer the patient essentially, right? So for example, knowing that this is a pro-inflammatory, kind of autoimmune kind of condition, it leads you to say, well, I know they have a ton of inflammatory mediators being released here, things like all these cytokines and whatnot. Like, let's go ahead and give you something to deal with that specifically, right? So that way that the treatment for rheumatoid arthritis is going to be a little different than osteoarthritis, which is kind of more of a mechanical issue with joint degradation over time. So being able to delineate between those two will allow you to choose the appropriate medication. So of course, you say, okay, well, I know non-steroidal anti-inflammatory drugs can be used for RA, right? So things like ibuprofen, other NSAIDs like naproxen could be possibly useful here. Again, you need to make sure that we can communicate the appropriate amount of information to the patient, because obviously most of them have a very poor medical literacy, and so by being able to say, like, okay, well, here's all these inflammatory cytokines that get released when your body's attacking itself. They're not going to get that, right? So you need to say, hey, your body can't tell you from anything else, so it's trying to attack you at this point, and the joints are taking a hit here. Or so there's lots of resources online that will help you with patient education. So next we need to say, what's our therapeutic objective? What do we want to do for this patient now that we have our tentative diagnosis? We kind of know what's the pathophys going on behind this. And so your objective should be set up here. So for instance, for RA, one of the things I want to do is to have relief of pain by relieving them of this inflammatory process. So I want something to have anti-inflammatory activity to deal with that. And I also want to prevent the disease from getting worse. And so in a lot of cases, you may be giving them drugs that won't make them feel any better, but it will prevent them from getting worse down the road. So with RA, RA, you'll find patients will have progressive joint destruction. You can have very significant effects on quality of life and their actual functional capabilities. Their hands are getting so distorted in the joints because of this damage. We want to prevent that. And so it's a different goal, and oftentimes will require different types of medications in order to deal with that. Okay, so this is where you can see multiple types of medications with different mechanisms are going to start to get involved in order to achieve these goals. So you want to select a drug of choice. Again, one or more groups of drugs may be used to try to satisfy these goals. We like to do one drug if possible, but sometimes you need multiple ones. And you need to take into account what's the age of the patient, what kind of other disease states do they have? Do they have concomitant diabetes? Do they have kidney issues? So that may make things like non-steroidal drugs a poor choice for that patient. Look what other medications are already on. Okay, so in this example for RA, does the patient have an history of aspirin intolerance, or they have an issue with GI ulcers? Because we saw that what was really important for producing that kind of protective coating around the stomach. Do you guys remember any hormonal? Yeah, prostaglandins are really important for that, right? And so if you give them a drug that blocks prostaglandins, you're going to end up degrading down that barrier. And for some patients, they're more prone to getting those GI ulcers. And so if they have a history of that, then maybe we need to choose a different type of drug, right? So when we get a form, you'll kind of figure out what the different options are going to be there. But look at things like, is cost a major issue? There are certain drugs we use nowadays to treat rheumatoid arthritis that can cost hundreds of thousands of dollars a year because they are very specific antibodies that have been formed to target specific cytokines, right? So it can be very, very expensive. So you need to figure out what kind of insurance they have. Obviously, health insurance is going to be a huge issue, kind of going down the line, depending on kind of how things go. Patients may not have any coverage, or they may have, not great coverage. And so that's going to directly affect, what you prescribe, because if the patient can't pay for it, they're not going to take it, right? And then, things like once daily dosing are going to be important. They're going to have issues with memory impairment, where taking 2-3 times a day drugs may not be great for them. One other thing to consider: some of the drugs that we give for RA nowadays are injectables, right? So the patient has to be able to coordinate themselves to be able to inject the medication potentially. And so if their hands are, they have really poor joints, and they're not able to inject that, you may not be able to use that type of drug. You may have to go to something else. So lots of things to consider. So next we want to determine what the appropriate regimen is going to be. So we can figure this out based on the kinetics of the drug. We can look to see how any organ impairment the patient has may be affecting this, which may lead us to alter the frequency we give the drug, or alter the dose that we give the drug. You guys remember when we were talking about the kidneys, what's an important thing that helps to keep the afferent arteriole open? Vasodilated. Nitric oxide is one thing that helps, yep. What's something we said that was important for the stomach? Prostaglandins, yeah, prostaglandins also help dilate that afferent arteriole, which is why patients with poor renal function who have the dependency on that prostaglandins, why they can have issues with non-steroidal drugs, because when you give that to them, you get rid of those prostaglandins, they can have the clamping down of that afferent arteriole, and all of a sudden they're taking a hit to their renal function, right? So you have to consider these sort of things to say, okay, is an NSAID a good option for this patient based on their other concomitant disease states, right? It's probably a good thing to remember for other tests you may have coming up maybe in the next week or two. So again, you alter the dose, the frequency, maybe choose which class of drug based on those sort of things. And then what will the patient actually tolerate? So how many times a day are they willing to take these medications? Are they willing to inject themselves with something? All these things you have to consider. So next, we're going to devise a plan for monitoring the drug's action and determining what our endpoint of therapy should be. So in a lot of cases, you may find that we're never going to be able to 100% correct the issue with the patient, but we want to have at least kind of measurable, attainable goals for them. And so you should be able to describe it to the patient, when you're just prescribing the drug, what's the drug going to be doing? What kind of things should they be looking for? Lots of patients will kind of live through a lot of these side effects and not realize that it's an issue with the drugs, not necessarily just their disease state. And so they'll, maybe manifesting these things, unless you ask the right kind of questions, it may never come up naturally, because they just think, well, this is just how life is now, and so they may not say like, well, oh yeah, I keep having all these stomach issues now, and I thought it was just the RA, and like, no, it's probably the NSAID you're taking. And then talk about laboratory testing if you need to do any kind of levels, or if you're monitoring for liver function, or things like that. You should be able to explain that rationale for why you're going to be prescribing it for a certain duration. So for instance, with antibiotics, a common problem you run into is you say, hey, take this antibiotic for 7 days. Okay, patient takes it, they start to feel better after 3 or 4 days, and then they stop taking it. Okay. You need to explain that rationale for why you need to take it for a period of time. If it's full 7 days, it's because this is going to get rid of the bacteria. If you stop taking it too early, you're going to select out for more resistant bugs or more likely to have the infection come back. Things like that. You kind of describe why they're taking for as long as they are. And then explain as well, what could constitute a change in drug therapy. So say, hey, if you notice that this sort of problem comes up, this is going to be an indication we need to switch over to something else. So you notice, hey, if you have evidence of GI bleeding, that's probably a good reason to go ahead and change drugs at that point. So if you notice, do you guys know what is a marker for or a sign of upper GI bleeds? Yes, they have dark tarry stool essentially. So basically, you're metabolizing the blood within the stomach, and then it gets passed through. So they get this dark tarry stool. So that's a good warning thing to warn your patients about. Hey, if you notice this is indicative of a GI bleed. We should probably get you switched to something else. Okay. So these are all kind of things you'll learn to educate patients on, depending on what you're prescribing for them. Okay, so next, plan a program for patient education. Find ways you can educate your specific patients. We have a lot of times running into age barriers. So if the patient is very, very young, obviously they're not going to be able to understand a lot of this information. Sometimes their parents are not much better off, but you try to at least make it as patient appropriate as you can. If it's a teenager, don't talk to them like they're a little kid. Say, hey, this is why we're giving you this medication. This is what we're treating you for. This is how it works. Language barriers are a huge thing. We have a ton of Spanish-speaking population. We have a ton of patients who come in from other countries, speak different languages. I always remember, one of our patients was from Brazil and was coming in and they didn't really speak a lick of English. And so one of our doctors, Dr. Perez, she was from Puerto Rico, and the medic came out. He's like, oh, you can go talk to them, right? They're from Brazil. She's like, no, you idiot. No, they speak Portuguese. I speak Spanish. Come on, it's not the same. So it could be language barriers, and usually there's some ways to help with that. So we have these nice iPads, kind of rolling iPads, that we connect with language services, so that way we can have interpretation happening actively, which is really nice. But you may not always have that available to you. Again, and obviously educational barriers, trying to talk to, some of these patients may not have a high school education, right? They may not really have any kind of health literacy, which could be affecting how well they understand what you're trying to describe to them. So utilize educational materials wherever you can. Diastat's a really good example of this. Diastat is this drug, diazepam. You guys ever heard of this one? You guys know what we use this for? Yep, use it for seizures. So this is actually a rectally administered gel that has to be given when a patient's having an active seizure. And so if you imagine if you have a kid that has seizure disorder and we're giving you a prescription for this thing that you're supposed to insert into their rectum and give it to them when they're having a seizure, right? That can be a pretty harrowing kind of experience, right? So kid's seizing, you're kind of freaking out, and then you have to give this medication. You want to have good education beforehand, or trainers that you can use to kind of show them this is what it feels like when you're actually using it. This is what how the thing is actually going to look and feel when you're getting ready to use it. And so we educate to a large degree to try to make sure we make this as smooth a process as we can for them. And then pharmacies will provide drug information as well, usually for new prescriptions, but don't always assume they're going to have the time to explain it to the patient. It'd be really nice if, the guys at Walgreens who are filling 400 scripts a day had a chance to sit down with every single patient. But sometimes the patients don't really care to hear it, and then sometimes the pharmacists are way too busy, and it's hard to find time for them to do that, which is unfortunate, but it's kind of the nature of the beast. So let's say, for instance, we have a 3-year-old. He's presenting with left ear pain. He's got a fever of 101.3. He's got cough and runny nose. What do you think this looks like? Otitis media. That's pretty angry-looking tympanic membrane. So we're going to say, okay, he probably has otitis media. So let's say for our first step, we're going to say he has an acute otitis media. We're going to figure out what we want to do. So again, you have to explain the diagnosis to the patient. Say, hey, do we think this is a more bacterial versus a viral etiology? Based on that, should we give antibiotics? Should we not? You guys are going to learn all of this when we get to ENT a little bit later on. But this is probably going to be more of a bacterial problem. And you can say, hey, this is what the pathophysiologic implications of this are going to be. And so when you have that background, you're going to know here are what the most common types of bacteria are going to be that cause an acute otitis media. So I know strep pneumoniae is going to be a type of bacteria that I'm worried about causing this, or H. influenzae is going to be a type of bacteria, right? So knowing that, okay, this is probably going to be more likely a gram-positive type of infection, or it's going to be a gram-negative type of infection, or maybe it's a mix of things. We mentioned if you have, say, a gut infection, what do you have to worry about covering for? What type of bugs? Yeah, anaerobic bugs. So you guys will learn this as we go through micro, as we go through bugs and drugs. You're going to hear this over and over and over again, because guess what? This is your bread and butter, right? Doing bacterial infections and trying to figure out, what specifically is causing this infection, how to treat that. This is going to be your bread and butter from here till the end of your career. So it's really good to have this knowledge and you get accustomed to it now. But anywho, so once you have, and again, this can change based on what type of vaccinations the kids had. So if they've had their H flu vaccine, maybe that's not going to be a potential causative organism for them, right? Maybe it's going to be more likely to be strep pneumo, and that will give us an idea of what type of antibiotics we should be using for them. Okay, so this helps us to narrow our spectrum. So we'll talk about antibiotic spectrum in regard to how many different types of bugs they can treat. So something like vancomycin, we said, kind of pretty much treats almost every gram-positive out there. That's a very wide spectrum. Like if we can try to narrow it down as much as we can, that helps us to use antibiotics that have much less likely to develop resistance. It kind of saves our bigger guns for those more serious infections. So, yes, ma'am. I'm just saying that if you're thinking the patient has a GI infection, this is what I should be thinking about as far as possible causative organisms go. If I see an acute otitis media, I'm thinking these type of bugs potentially causing this, right? There could be some viruses, but you're thinking things like strep pneumo, or thinking things like H1 influenza, right? So, anyway, you're going to be providing information to the families saying, hey, this is what I think it is. Here's why I'm using the antibiotic that I'm using. So then, again, you can always kind of guide them to online resources. This is very useful. I mean, things like the CDC can be very good for kind of explaining, here's what ear infection is. Like, hey, they can read up on it extra if they want to see, other things about it. Oftentimes, your patients are already coming to you with a high amount of information because, again, they can Google all this stuff. They probably went to WebMD and they're like, I think I have cancer. You probably don't have cancer. But I read about it, it said I had a headache, so I probably have a stroke and cancer. You probably don't have a stroke and cancer, okay? So these kind of things. So they'll probably come in with their own kind of background set of knowledge in some cases, or these kind of biases already, but you can kind of guide them to the correct kind of information. So like CDC is a really good example. They're Up to Date, which is a reference you guys will use very extensively from here on out, is going to have good patient education leaflets that are available. And so things like that. You want to guide them so they kind of know what they're dealing with. So we want to go ahead and select our therapeutic objective in this case. So we're going to say, okay, goal 1, we would like to eradicate that bacterial infection. We'd like to get rid of that. So we've got to use appropriate antibiotics. And then we want to also treat the sequelae of that disease state, right? So the kids having cough and runny nose or having fever, maybe I can give them an anti-inflammatory to deal with the fever, right? So something like an antipyretic that we can use for that. So those are kind of the goals, and that'll guide you what medications you're going to use for them. So we're going to select our drug of choice. Take the patient factors into account, so look at their age, organ function, if they have allergies. This is also a really important thing to consider when you're looking to treat bacterial infections. They come in, the kid says, oh, I have, parents say they have a penicillin allergy. That can knock out a huge amount of drugs that you may or may not be able to use based on things like, well, what type of allergy was it, what type of reaction, things like that. But consider allergies. Consider, have they had a previous round of antibiotics that oftentimes will lead you to have more resistant bugs, which may guide you to choosing a different antibiotic, or if they have other concurrent medications that may be affecting this. So again, use your appropriate resources. So if you guys had to go and look how to treat a bacterial infection like an acute otitis media, where would you guys go look? Up to Date. Up to Date's a good one. I will tell you that Up to Date is you guys will use that probably as gospel from here on out. I will tell you there's a small amount of caution with that. Up to Date's very, very good, but they will inject a little bit of personal opinion into their stuff, and it may not always be super clear as when that is. Up to Date, it gets reviewed, it gets edited, pretty frequently. But a lot of times, if we don't have good answers on something like, what's the best way to do this sort of thing, they'll say, well, at our institution, this is what we do, and then people will read that and say, well, this is what everyone does then. May not be the case. So just realize that caveat. Otherwise, Up to Date is great. What other places could you look? Books. Yeah, you can look in textbooks. That'd be one way to do it. Other drug references. There's one thing we have called the Red Book, which is really good for pediatric infections. You guys ever heard of the Sanford Guide? Yeah, so the Sanford Guide is really, really useful. We'll go over that. You actually have access to it through the library, which is a great resource. It comes out every single year, and it actually will guide you through, okay, here are, you have this type of infection. Here's the most likely bugs. Here's the most likely drugs that are going to cover it, right? Give you the dosing right there. It's a great guide. I'll kind of show you guys how to use that when we get to bugs and drugs and pharmacology. But you want to use your resources as appropriate. Also consider things like guidelines. Like there's a whole Infectious Disease Society of America. Go check them out. They have lots of great guidelines to show you. Here's what the research says about the best way to treat these things. So LexiComp's another good one I would recommend checking out, which you have access to the library. It's also the same company that Up to Date owns both of them, and so you can get that information to it very easily. Clin Pharm I also like quite a bit. Yes, ma'am.
Do you like Hippocrates or
I don't It's nice because it's free. I don't necessarily jump to it as my go-to reference. They probably have some good information there, but when you get to like working in a specific institution, they will probably have licenses to not to say better resources, but things that may be kind of more geared to what you're doing, right? So for instance, like LexiComp is really nice because they have a whole pediatric Lexi that will, you know, for at least at Nemours, and that way it's all kind of custom tailored to treating those type of patients. So Epocrates is okay, just like your Tarascon Pharmacopoeia is probably okay as well, but you'll find there's little differences between every reference out there, which is kind of outside our scope here, but that Stanford guide. This will probably be kind of like your Bible for treating infectious disease stuff, and so a new one comes out every year, but so it's nice you guys have access to it now. So we'll probably go over that some other time. But clinical practice guidelines are huge. So in this case of treating acute otitis media, we would look at things like the Infectious Disease Society of America. We'd also look at places like the American Academy of Pediatrics, right? Because they would be more focused on this being primarily kind of a PEDS condition. They would have guidelines as well potentially. Okay, so then we want to see, okay, what type of drug do we want to select in this case? So we have to look at how often is the drug given. How easy is it to give medications to a little kid? And they're already kind of like angry because they have fever and they don't feel good. Not super easy, right? So if we can give it less frequently, that's going to be super useful. What type of dosage forms do we have available? You know, do we have it available in a liquid formulation? It'll be easier to give to that child. You know, they have to consider things like drug shortages. Like we run into that all the time. You think, you know, sodium bicarbonate. Right, you think baking soda, that should be pretty easy to get a hold of, right? No, we're having a national shortage of that right now because of issues with sterility issues that are happening from the manufacturers. That's a major back order we have. So always have to consider drug shortages. How much does the drug cost? You know, does the patient have insurance? Are they on Medicaid? They can get, you know, pretty much anything. Are there free antibiotic options? Can they go to Publix or Walmart? You guys will probably have lists or at least know as you start to practice, okay, these are the places where you can get cheap drugs, right? So that can be very useful to know. And then how palatable is the medication, okay? You may think, oh, this tastes like bubble gum. It's probably good enough for a kid. They may hate that taste. So are there options to flavor it with something else? You know, can it make it taste like orange or cherry or whatever the kid will actually tolerate? I think cherry is actually like universally like panned by most kids. Grape's usually pretty good for the most part, as I'm learning. So if you were to look at the treatment guidelines for an acute otitis media, I can't remember if this is IDSA or AAP. I think it's probably AAP, but basically what you'll find in these nice tables are they kind of summarize the information. So you'll say, okay, well, I think I have an acute otitis media. Here's how I want to treat it. And they'll give you first line recommended treatment, and they'll say, okay, well, let's use amoxicillin 80 to 90 milligrams per kilogram per day in 2 divided doses. Okay, seems pretty easy. Or you can do something even a little bit bigger. So we'll talk about this combination drug here, how this can have a little bit wider coverage. But and then you'll also have alternative regimens. You always want to have a backup in your mind when you're trying to prescribe something, especially antibiotics. So if the kid had a penicillin allergy, okay, let's use something different. Let's use this drug called ceftonir. This one will be nice because it's only 14 mg per kg. Only one time a day you can give it potentially. So that could be one benefit there. And so, of course, you know, you're going to use these as kind of your first line options. Hopefully this will get the patient better, and if not, they may have to come back and get something different based on if you have treatment failures, right? So you always kind of consider these other options as time goes on. But you'll find different guidelines will have, you know, a little bit different way of displaying this information, but these tables are very nice and kind of helps you out with that. For instance, you know, if I had a patient who was having significant vomiting associated with this and they really couldn't tolerate oral medication, so I can look down here and I can see, oh, I have this drug called ceftriaxone or Rocephin. I can give this IM or IV. That could be a really nice option as well. I can have the patient actually come back for 3 days and get an IM shot of this if they're not able to tolerate oral. So, you know, it'll give you options essentially. You always want to go with the first line option if possible, or one of these alternatives based on, you know, the patient's condition. So now that I'm selecting, okay, I want to do amoxicillin, I'm going to do 90 mg per kilo per day, divided twice a day. Let's say the suspension comes as 400 milligrams per 5 ml, and the patient weighs 20 kilograms. Well, how many ml should the patient get? Going back to the math, right? Let's cover this a little bit already. Let's say, oops, I don't know my timer. I'm not checking my Instagram, just so you know. I'm doing the math with you guys. Okay, so let's say we're going to do 20 kilos. So we're going to do 20 times 90, so we're going to figure out how much he's getting in a whole day. So he's getting how much? 1,800 milligrams in a day. So basically he's going to get how much per dose? Yeah, he's going to get 900 milligrams per dose. We're going to get 900. And then we need to figure out how many mLs that's going to be. So if we know it's 400 per 5, that would also equal what per 1? Yeah, so it's going to be, sorry, 400. Yeah, it's 80, sorry. Right, so it's 80 milligrams per ml. Right? So we're going to take 80 milligrams, so we'll take 900 divided by 80, and you get 11.25 mLs, get you beginning per dose. Okay, so that would be on your prescription. You would say, hey, we're going to give 900 milligrams twice a day of amoxicillin, 11.25 mLs. You'd also want to write that on there so that way the patient knows how much they should actually be getting, right? And the pharmacist can double check and make sure the math actually works out for that as well. Okay. So yeah, and it's nice I put the answers right on the slide for you, but I forget about it, so I can at least do it with you, and we can have that experience, right? Okay. So after that, so we figured out what our dose is going to be. We figured out what we want to prescribe for the patient. Then we need to figure out what our monitoring plan is going to be. Make sure that we achieve those endpoints. Make sure we eradicate that infection in this case. So again, you should be able to describe to the patient what type of effects to monitor for, both with efficacy. So you should say, hey, after a few days, you should start to feel better. Fever should start to go down. Should start to get rid of some coughing, runny nose, and all this kind of stuff. And continue taking the medication though. Make sure to take it the full time frame. Look for adverse effects. Hey, you may see some diarrhea associated with this. Hey, if you see rash or hives, or they start to complain about their breathing, like that's an indication maybe this is not the right drug for them. Get them to ER, right? So you need to be able to describe this. Make sure to take the full course and understand that, hey, this is a bacterial infection. We want to get rid of it. You need to take the full course. And then also, what would also constitute change of therapy? So I mentioned that allergic reaction. What if they're taking it for the full course and they don't feel any better, right? That could be an indication of a resistant bug. They may need to come back after a period of time and get something else done, or use a different type of antibiotic. So next, plan a program for patient education. Make sure you're addressing things like age barriers, language barriers, educational barriers, and utilize any kind of materials you can. Usually a lot of places will have kind of pre-done printouts that will already be generated based on the type of diagnosis you make, which is nice because it'll already be kind of pre-done for you. You can hand it to them, say, hey, if you have any additional questions, let me know. Okay, so let's look at prescription writing real quick. So that kind of makes sense as far as the steps of kind of rational prescribing. It may seem kind of obvious, but you'd be surprised how many people don't necessarily follow that. So anyway, you guys will though, because I have taught you. That's one of my goals, to teach every PA farm in the Central Florida area. So at least I'll have these PAs that I can work with, and they'll know what they're doing, right? Ulterior motive. So anyway, again, a prescription can be written, it can be verbal, it can be electronic order form that the practitioner is going to be fulfilled either by the lab or the pharmacist or whoever is going to be receiving this, right? Who can prescribe? And again, it can differ from state to state, but in general, your physicians, MDs, DOs, obviously your mid-levels like your nurse practitioners, PAs, podiatrists, veterinarians. It's funny when you get a prescription for, this I remember getting one, there's like a massive amount of an antibiotic. I'm just like, who in the world would take this much of this drug? And I realized it was like, some kind of Burmese mountain dog that would need to be treated for an infection. I was like, oh, well, that makes sense. The dog weighed, 200 pounds or something. Great. This is a huge dog. Anywho, optometrists. So there may be other prescribers out there who can write for valid prescriptions. And all of that's going to be set out in the state statutes, right? Always keep in mind there is going to be state and federal laws. And which one should you follow? Is it always a state? You go with which one's ever stricter, okay? So for instance, if the federal law does not say anything about it, but the state law says that, then you follow the state, or if they have competing things and the federal is more restrictive, then you can go with that, right? Basically that will keep you out of trouble for the most part. And again, if it's not addressed in state law, just follow the federal law regarding that. So all prescriptions should be legible. Please, please, please make them legible. They should be unambiguous. We should be able to look at that and know exactly what your intent is based on the prescription that you write. And again, most places you probably are never going to have to actually write a hand prescription for a patient. You'll probably always do it electronically from here on out. But just in case stuff goes down, you should be able to write one by hand. I mentioned that one doc who went all the way through her medical training, finished fellowship. She's a peds ER attending, and the computers went down. She had no idea how to write a hand prescription. Never done it in her life. So you guys will probably at least have some training in that, but we'll talk about it here. So, and again, should be providing enough information that people can follow that, follow your instructions really without any kind of errors. Okay. And again, you guys don't want to have unnecessary phone calls from a bunch of annoying pharmacists. So this is why you want to write good prescriptions, right? Basically, prevent you guys from getting annoyed by us. We can be really, really annoying if we're going to write good orders. Okay, so the basic requirements when you have a prescription, this is for non-controlled substances. So what would be an example of like a controlled substance? Morphine, Percocet, yeah. So again, we'll talk about our narcotics in just a few minutes, but these are for non-controlled substances. Again, if they are written or typed, should be legible. You had to put that into a law because, again, most people try to write these unlegibly. It has to include the name of the practitioner, so we know who's writing for it. It needs to have the name and the strength of the drug prescribed. Again, probably pretty straightforward. The quantity of drug to dispense, and again, what you're writing for should match what the quantity is. So if you're writing for something that's given twice a day, and they're going to be receiving it month after month, like write for a quantity of 60, right? So a quantity of 30 would initiate a phone call because, like, well, is this actually right, or are you only trying to do this for half a month? Should include the directions for use, so 1 tab twice a day. You know, usually use as directed we kind of frown upon unless it's like pretty obvious. So if it's something like a Z pack where the drug already comes with instructions, hey, take 2 pills on day 1, then take 1 pill on day 2 through 5, that's pretty self-explanatory. But in a lot of cases, you need to include directions for use. We don't like use directed as much as we can. Needs to be dated, so again, you don't want to like predate a lot of prescriptions, so you write the date that you actually wrote it, and then it can be signed by the prescriber on the actual date that it was issued. So you can't really pre-sign a bunch of stuff and then hand them out to whoever wants to kind of write for themselves, right? You want to do that. So you want to sign for it the same day you write for it. And so these can be called in or they can be electronically communicated, which is nice. And then once we get it over in the pharmacy side, we can reduce it down to writing essentially. So that's why you can call in scripts, you can fax them over, you can do whatever you need to do. We can get a hold of those. We'll see there's going to be some restrictions on that when we get to the controlled substances in just a minute. And then in general, every prescription is going to be good for 1 year at most. Okay. Certainly you can write for, you notice how refills isn't on here because you may not always be writing for refills, so you don't necessarily need that. But if you write for, I'm going to write for 24 months worth of refills on this script, it doesn't matter. It's always going to expire at the end of the year. They'll always have to come back and get a new prescription. Okay. Okay. You can write multiple scripts on the same prescription. That's totally fine, especially if they're non-controlled. We'll look at when you want to separate those out. But in general, you want to keep controlled substances separate. Again, that helps us with, we do a lot of record keeping on our side to keep all those prescriptions. And so, and especially C2s, we'll talk about what a C2 is in a second, but those really have to be kept by themselves. That is per the I can't remember if that's federal or not, but it is per those laws that they need to be kept on a separate prescription. An example of a prescription here, you can see, okay, we have, a lot of times you're going to have pre-done prescriptions that already kind of have most of your information already on there, which is good. So we have things like your license number, the DEA number, which can be very useful. Do you guys know where DEA numbers come from? There's actually a special code to it where, actually I don't even know how to do it, but essentially there was a way, and for a time there was a period where people didn't know what the actual method was, but pharmacists could go and check to see if the DEA number was correct or was a valid DEA number by doing some sort of alchemy or some sort of black magic to add and subtract it and multiply it to actually see that, okay, yes, this comes out to be a certain value, yes, this is an accurate DEA number. So nowadays people know that, so they can fake any DEA number they wanted, but that is, we'll also include that there. This is really important for controlled substances. So you really need to have that. NPI number is another good way to identify prescribers as well. So again, you'd have the name of the patient, have their date of birth, which is good. This helps us to keep people from mixing them up and filling a prescription under someone else's profile. So that's very useful to have. The date it was written for. You don't necessarily have to have the patient's address on there, but this is again a useful piece of identifying information. Helps us prevent errors from occurring. It's nice to include allergies, make sure we don't accidentally prescribe something or fill something that the patient should not receive. And you would have your drug, your metformin. You don't have to write the brand name. Some people will do that. Some people will only write for the brand name. But if you write for a brand name drug, can we switch it out for the generic?
Yeah, let's take a
100, yeah, so we can absolutely do that. We because it's in the interest of the patient from cost perspective, we can absolutely do that, unless you write dispense as written. If you write DAW or dispense as written, that means we have to give them the brand name drug in that case, or if we don't have it, we have to order it and give it to them. So again, that's at your discretion, but in most cases it doesn't matter, right? So if you write for brand name glucophage or glucophage, like we can just change that out for generic metformin. That's usually no problem for the patient. Okay. So again, you write for the strength of the tablets, number 100. They're going to take 1 daily for control of diabetes. It's really nice if you include an indication. For some drugs, that's readily apparent. There's not a lot of cases where you give metformin for something else, but it's nice if we have that on there. Helps to kind of delineate what your thought process was for prescribing it, so that way we can make sure the dose makes sense, the quantity makes sense, all of that. And so so they're taking 1 daily, but they're writing for 100. Does that make sense? Is that cool? You can do that? Yeah, so basically it's a 3-month supply, so you can certainly write for that, but again, a lot of it comes down to what their insurance will cover. Some places they may only do one month at a time, so in this case we would actually alter the refills so that way that they could still get a total of 400 tablets for this prescription, but we would only prescribe or dispense out whatever the patient would actually be able to get covered under insurance. So we can kind of play with that a little bit. A lot of cases that the insurance will cover 3 months at a time, but if you wrote for like 100, the insurance company may only cover 90 at a time. So we'd actually kind of fudge that as well and say, okay, well, we'll give you 90, and then you can come back and get the refills for that. So there's a little bit of play we can have to make sure the patients are getting what they need, via their insurance and whatnot. Yes, ma'am. Yes, the pharmacist will do on the pharmacy end. We'll handle all that.
Okay, and is that ever communicated to the doctor?
Not usually. It's not usually one of those things that initiates a phone call, unless we need, as long as we're not having to like clarify the order, or so things we cannot change. We can't really change the dose that we're going to give the patient. We can't change the strength of the medication we're going to give to them. We can't change those sort of things. But if it's an issue of like when they actually come back to refill it the next time, like that's stuff that really doesn't matter, right? So we can kind of monkey with that and make it so the patient's getting what they need. Yep. Yes, ma'am.
Can you use shorthand when writing prescriptions? Like, can you write QD, or you have to like? Yeah.
Should you use QD? Never. Yeah, QD is an unapproved abbreviation. We'll talk about unapproved abbreviations in a little bit. It's always nicer if you can type it out, or if you can say it out. And again, most of the time when you're doing these electronically, like you'll hit the button that says once daily, and it'll just automatically pop it on there, so you don't have to worry about it. But it's nice if you can write daily. Usually, if you just write Q daily or something, you're going to find there's some errors that can come about from that, which we'll look at in just a few minutes. Yep. Okay, so any questions on that? So again, of course, you would sign at the bottom on the prescription there. You could also, for non-controlled substances, you can do things like a stamp or something like that would be totally fine. Because again, you can call these in, you can electronically send them, so we wouldn't get a signature in that case anyway, right? So prescribing errors, some common things we run into: omission of information, resume pre-op meds. We don't like to do that. We like to make sure that when you have patient conditions can change pretty significantly when going from different stages of care, and so that's why, like in our institution, we always make sure that the provider has to do a full med rec on everything they're receiving before to say, hey, do I want to continue this? Do I want to stop this? They have to go through and make a conscious decision on every medication rather than just giving a blanket order, because not all of those meds could have been appropriate after something like surgery. Continue present IV fluids. You need to be specific about what you're saying to continue. I want to continue D5 NS at 125 mLs an hour. Be specific when you're saying these things. Again, we like the prescription to be very specific. If you may fail to discontinue the prior med when starting a new one. So again, a lot of times patients will say, well, I just got this new prescription, I'm going to keep taking the old one until that one runs out, and then in addition to this. It may not be the case. So really be specific with your patients. Say, hey, stop taking this other one. I don't care if you have extra. Get rid of it. You don't want it hanging around. And then start taking this new one instead. You may need to indicate if it's a long-acting or short-acting medication. Some of them will have multiple forms, and so if you don't indicate what that's going to be and it's not really readily apparent on the prescription, we may have to call you up and get that clarified. And then as needed. So again, you can write, do you guys know what the abbreviation for as needed is? Yeah, PRN. So if you write just, take Lortab, Q6 hours, PRN. Okay, it's not super specific. The patient's going to be like, well, what do I take it as needed for? Is it every time I have pain? Is it every time? So try to be specific, and in which case, and this is a big thing on the hospital side, because if a patient has multiple medications that are all PRN, so for instance, it's not uncommon a patient in the hospital to have a prescription for, or an order for acetaminophen, Q6 PRN, for ibuprofen, also Q6 PRN, and then for like an opioid pain medication like oxycodone. Okay, so if they're all PRN for pain, and the nurse comes in and she has to decide which one to give, and there's no specific indication on there, now she's independently prescribing. Okay, and we can't really have that. The Joint Commission, which is a major organization that accreditates hospitals and makes sure we get funding, we get a reimbursement from things like Medicaid and Medicare. We have to have a specific indication. So, for instance, at our institution, we did that by instituting pain scales. So again, if you ask a patient, hey, what's your pain on a scale of 1 out of 10? 1, no pain whatsoever. 10, I'm cutting your arm off with a chainsaw. The nurse asks that question, and so based on it, say, okay, well, acetaminophen's 1 through 3. I can give ibuprofen if it's 4 through 6, and then for oxycodone, it's 7 through 10. So that way the nurse has very specific indications. The patient said their pain was this. We're going to give this medication now. Okay. So again, we like PRN to be as specific as we can, especially for patients who are taking it on the outpatient side. They know exactly when to take the medication. Okay. All right. An example of poor prescription writing. Even I can't read that. I have no idea what the guy's trying to prescribe there. So again, really, e-prescribing is helping to supplant a lot of these issues. So it's very rare that we get a lot of handwritten prescriptions anymore. Most of them are kind of already pre-filled out for the most part, which is very nice. But again, don't write like that. That's probably how my prescription would look if I ever wrote one, but don't do that. Okay, other types of errors. Misplaced decimals is really important. That if you have something like 0.1 written, if you just write 0.1, they could easily be read as just 1. Okay, it's a tenfold overdose. We don't want that. Okay, so you always want to precede decimals with a 0. So if you're writing for 0.5 milligrams of something, write 0.5. That way it's very clear. Writing for unnecessary zeros after the decimal. You just can write 1. You don't have to write 1.0 because that can be misread as 10, and again, another tenfold overdose. We don't want that. So again, if there's nothing after the decimal, don't put anything there. So if you're writing for 5 milligrams, just write 5, not 5.0. Other things, misreading U as a 0. So again, you may think like this seems pretty obvious when you're reading it as like an electronic, when it's typed out. If you're actually looking at handwriting, you can see how these can be kind of screwed up. For instance, if you're writing for 10 U of insulin, insulin's usually dosed in units, that can be misread as 100. Okay, that's a big overdose of insulin that can kill someone very easily if they accidentally got that. So this is why we always like to write out certain things like units. So you never write for 10 U of something, you write for 10 units of something. Other issues, micrograms, if you try to write that U or that mu there, being misread for milligrams, it could be a 1,000-fold overdose. Not good. You usually don't want to cause a 1,000-fold overdose for patients. So we use MCG instead. That's going to be much more easily delineated from MG, if that's written out. Okay, and then QD is a huge one. This is one absolutely do not ever use. So instead, just write daily. It's just easier, and that way you can have issues where something like QID could be mixed up for QD, instead they get it 4 times a day instead of once daily, something like that. So just always write out daily. It's useful there. And then this really isn't a problem anymore nowadays, but writing out full drug names, the common error that used to occur where they would write for MSO4, it got confused for MGSO4. Do you guys know what the difference between these is? Yeah, so one's morphine sulfate and the other one's magnesium sulfate. If you need morphine, you probably don't want magnesium, and if you need magnesium, you probably don't need morphine. So screwing those up could be problematic. Okay, so this is why we just write out the names, and it's much easier to differentiate the two. Other things, failing to include the strength and the dosage form. You can have multiples of each that can lead to errors if we accidentally misfill it for one versus the other. So be clear about that. And then don't write in teaspoons or tablespoons. In general, we're moving away from that. A lot of drug packaging is getting away from this. Just write in mLs, right? So that way, and we'll give them dosing syringes so they can actually drop the right amount instead of having to guesstimate if their spoon is holding 5 mLs or not. Definitely includes the quantity of drug. Make sure the quantity makes sense based on what's getting prescribed. So if it's a one time daily and you write for 100 at a time, like if we can make sense of it, then we can fill that. But if you write for twice daily medication, you only write for 30. That may not make a total amount of sense, right? So those are cases where we need to be able to delineate between those two. And then, as I mentioned, the brand name thing. If you really want to have brand name, then you have to write DAW or dispense as written. Otherwise, we will automatically substitute. There's a negative formulary where there's a few drugs we cannot do that with, but that's a pretty exceedingly rare kind of indication. So again, just write dispense as written if you want it. You think I see this very often? I don't really do a lot of retail pharmacy, but how often do you think I actually see that? Almost never. Yeah, most of the time people don't care, right? So you'll find that generics work in general just as well as the brand name, so it really doesn't matter. The patients may say otherwise, right? Oh no, the blue one definitely works for me. The blue one probably doesn't actually make any difference, but you may find that certain brand name opioids tend to sell for more. That could be one issue you run into. So. Anyway. So again, just looking at common abbreviations that you can run into issues with. So things like we mentioned the micrograms being mistaken as milligrams. I'm not going to go through each one of these, but just some other things that can come up into issues. OD can end up coming up as once daily. So instead of just write I, it ends up coming up as receiving it daily. So that can be confusing for the whoever's dispensing it or whoever is taking the medication. So just be aware. In a lot of cases, your institutions will have an approved abbreviation list, and so you'll have an idea for what kind of abbreviations you can use, which ones you should avoid.
So does it matter if you put the generic or brand name when you write the script? Doesn't matter?
Yeah, so if you wrote for something that only has a brand name drug and you wrote for the generic form of it, we would just have to fill the brand because that's the only thing that's available, right? But if you wrote like Lucafage instead of metformin, like we would just sub it for the generic form. Okay. Other things. So again, take as directed or use as directed. We generally will avoid that unless it's like super apparent to the patient what they should be doing. Here's an example of a methylprednisolone dose pack. They basically tell you first day, take all of these. Second day, take all of these. Third day. And that's pretty apparent. So again, makes sense. But if it's like their insulin, take as directed. Like, okay, well, how were they directed to take it? Like, so that you usually need to be more specific. If your blood sugar is between this and this, take this many units. If it's between this and this, use this many units. So try to be more explicit on things that are not readily apparent. Okay. Be careful with drugs that have different dosage forms. So we run into this on the emergency standpoint in ICUs when they say, hey, give me an amp of calcium. What's an amp mean? It's not what I hook my guitar up to. It's an ampule they're trying to refer to it. We don't have a ton of drugs that actually come in ampules anymore. So one, that's already inaccurate, but people still say it. And they say calcium. So we have calcium gluconate and we have calcium chloride. Both of these live in the crash cart. I won't give you go into detail on why we would use one versus the other. But notice how they're both a 10% solution. They both come in a 10 ml vial. So the question is, well, can I just switch these out? Well, no, I can't, because this actually has 3 times as much elemental calcium and calcium chloride as does the gluconate. So the dose changes pretty significantly, and how much I need to give that patient also differs greatly. So you need to be very specific. Hey, I would like I want 10 mLs of calcium gluconate in this patient. I want 10 mLs of calcium chloride, right? So again, be very specific. We ran into that. Just recently we were coding a kid, and the cardiac unit was coming down, and they were just like, give me calcium. It's like, well, what type of calcium would you like? What dose do you want? Because we need to be specific here and make sure that we're treating the patient appropriately. Other things, so sodium bicarbonate mentioned are kind of on shortage for this. They say, give them an amp of bicarb, stat. Okay, well, what are you referring to specifically? We have 2 forms that are available. One's going to be an infant formulation, is in this 4.2% versus this 8.4%. Okay, this one comes as a 1 ml equivalent per ml concentration. This one's 0.5. So if you give the wrong one, you're going to be given a wildly different dose, either doubling it or halving it, and that may not be appropriate for that patient. So just be careful of that. Be like, what concentration would you like? 8.4%? Okay, I can get that. And then again, not being specific with your unit. So again, start the patient on 20 of dopamine. What do we use dopamine for? Yeah, use it to raise blood pressure typically. So okay, well, do you want that in milligrams per hour? Would you like that in micrograms per kilogram per hour? How about micrograms per kilogram per minute? Would you like in micrograms per minute? This makes a huge difference in the actual rate that drug is going to be infused into that patient. I've seen entire bottles of nitroglycerin infused into a patient within a few minutes when they meant to run it at a very much slower rate because they screwed up and said they wanted to give milligrams per kilo per minute instead they just ran it milligrams per minute and just ran the whole thing in. I'm sorry, they reversed that. They wanted certain milligrams per minute. They did milligrams per kilo per minute, and based on the patient's weight, they multiplied it out and they ran the whole thing in. Patient got a huge, massive headache, got a little hypotensive, ended up doing okay, but you need to be very specific. So for dosing in mics per kilo per minute, you need to say that. Because when you're like in an intense kind of like emergency type situation, people tend to like just shout things and expect them to happen. But sometimes you have to be the voice of reason and be like, okay, well, slow down a sec. What is it specifically that you want? Okay, I can get that. I had one patient who we had a cardiac arrest. We were trying to get an epi drip started up for her. And so I was busy doing something else, getting a drug ready. And the nurse was like, okay, well, how do I make this epi drip? And she was getting trained. And the other one's like, okay, just take the whole thing of epi and put it into that bag of saline and we'll just hook it up. Okay. So what the trained nurse was referring to was we have these syringes of epinephrine, usually a milligram in the whole syringe, and we would inject that into the bag and then run that. We know what that concentration is. There's also a vial of epi in that code card as well that contains roughly 30 milligrams of epi. And so when the trainer nurse was like, hey, should I just do this whole thing? She assumed that she meant the 30 ml vial. So she injected the whole 30 mLs into that bag and then hung it, almost got to the patient. I was like, wait a second, what did you just inject there? She said, oh, a whole vial. And I said, okay, let's not do that. We would like to not cause this patient to have a stroke on top of his MI. So he died anyway, so it probably wouldn't have mattered. But point is we averted a potential error there. So again, be careful when you say, hey, should I use this whole thing? What the heck are you even talking about, right? So be cognizant. Sometimes you have to be that voice of reason in the chaos. Okay, some other inappropriate prescriptions could be written due to not being cognizant of contraindications, certain interactions, and if you don't get a full medication list. You have to ask about OTC drugs, ask about herbal medications, otherwise you may miss very important points. I had a patient who came in, she was taking warfarin, and hey, I'm getting older, I want to help my memory, I'm going to take ginkgo for this. Takes ginkgo, does not realize it had anti-platelet activity, and then had a huge hemorrhagic stroke and died. So you got to be very, very careful and ask these kind of questions to see what they're taking, that you were not prescribing to them. Other issues, if you have incompatibilities between drugs, so if things are infused inappropriately, they can precipitate out, and you can either lose a line at the most benign circumstance, or they can precipitate out in the patient and cause things like emboli and whatnot. And just be aware of different disease state interactions that can pop up here. How many slides do I have left in this? 10. You mind if I finish this up? Awesome. That way I don't have to do another video. So compliance, also referred to as adherence. We like our patients to be compliant, but again, how well is your patient going to follow the instructions? There are kind of 4 types of non-compliance. Patient fails to obtain the medication. Either they can't afford it or they forget about it. I can't tell you how many prescriptions I have coming from ER docs for an antibiotic and a pain medication. They say, I'll just take the pain medication. You sure you don't want the antibiotic for that toothache you came to the ER for? I'm good. Okay. That's non-compliance. Patient fails to take the they always fill the narcotic for some odd reason. It's very strange. I don't know why that is. Okay, so patient fails to take the medication as prescribed. So again, you were prescribing it a certain way, they decided to take it a different way. Sometimes that can be intentional, sometimes it's unintentional, just depends. Patient prematurely discontinues the medication. So they say, hey, I'm feeling better, I'm going to stop taking this. That is also non-compliant. And then if they're taking it inappropriately, so they're either self-dosing or, for instance, their pain's not well controlled, so they're taking additional medication or help cover that, also could be non-compliance. So again, if I have a patient who comes up to the pharmacy and they say, hey, I'm here to fill my oxycodone, and I say, well, it's kind of early. You could be thinking, hey, well, maybe the patient is trying to get extra meds to either sell them or to abuse them or something. But in some cases, patient's pain is not well controlled, and so they end up self-medicating, and they run out early, right? So that could be a reason why you may need to address, well, perhaps we should give you more medication, or perhaps we should change the type that we're using. So in some cases, they can be legitimate, but sometimes you get a little jaded by the ones that are not so legitimate. So anyway, patient, again, failing to take the medication, about a third of them never have their prescriptions filled, even though they really wanted one from you in the first place. Usually this is either due to cost, could be difficulty in finding the product, whether due to drug shortages or something else. A lot of times we'll write for medications that are either hard to get a hold of or it's the wrong time of night. If you write for something at 12 o'clock at night, there might not be a 24-hour pharmacy near them, right? So that could be difficult to obtain the medication. Or they have a lack of perception. So the guy coming up saying, hey, I showed up to the ER for a toothache and I don't really want the antibiotic. Well, okay. Okay, so if they're failing to take the medication as prescribed, could be the issue of they're taking the wrong dose, they're taking it either less or more frequently, could be by the wrong route. I can't tell you how many patients I have that would, there's an inhaler called Spiriva that we use for our COPD patients or chronic obstructive pulmonary disease. And basically it comes as a little capsule, you put into the special inhaler, you pierce it with the button, and they inhale that. And I can't tell you how many old people call up the poison center saying, oh, I accidentally swallowed my Spiriva. Fortunately, it's not a problem, but again, that's the wrong route they'd be taken to by. They have a wrong technique of medication, so either due to improper education or if they have kind of physical disabilities that prevent them from using it appropriately, so inhalers are a huge issue with this, or if they have kind of inadequate communication or understanding of the instructions you gave to them. So again, if you take 2 tablets by mouth twice daily, what does that mean to your patient? Does that mean I take 1 tablet in the morning, 1 at night? That's 2 tablets. Or should they be taking 2 tablets in the morning, 2 at night? So make sure the patient, we often do a teach back method with patients where you say, hey, this is what you should be taking, now you tell it back to me, and that way you can make sure they actually understand what they're supposed to do. If a patient will prematurely discontinue medication, I mentioned the antibiotic example, which is probably the most common one we run into, or if the bottle's empty, so I must be done with the medication. Well, there's probably some refills on there you're supposed to refill it with. Those are questions that can be answered. Or if they feel like they are not getting any benefit from the medication and they stop taking it early. So this is a good example for antidepressants. You'll learn the antidepressants, they take like up to 6 weeks before they really start to kick in. So the patient could be sitting there taking it for weeks and they're like, oh, I still feel depressed, I still don't want to get out of bed in the morning. That's something where education can help to get around that, to make sure that, hey, take it for the full 6 weeks, let's see how you're doing, and then we can reassess. And then, patients may share medications with one another, like, oh yeah, I had this infection last December, here, you should take whatever I have left over. That's a common one. Medication abuse, so again, people will either self-medicate themselves or they'll take someone else's medication. I actually had this happen, so my mom has a host of health issues and she has some chronic pain issues as well, and we had some cleaning ladies that had come over, and basically, like, my dad was kind of going through her meds and was like, oh, it looks like you're missing some of these hydrocodone. I wonder what happened to them. That is odd. And so ended up going out and he was putting out the trash or whatever, and then found this like big wad of tissue paper in the trash can. He ended up looking through it, and sure enough, there's an empty pill bottle there. It's like, okay, maybe these cleaning ladies should not come back to our house ever again. So again, keep in mind, people lie, cheat, and steal sometimes to get this stuff, and so they can get from multiple sources. Okay, so controlled substances. Good thing to mention here, because again, back when I was initially training, like you guys could not write for controlled substances in Florida. That was kind of a long-standing. There's lots of states where you could, but it was always one of those things where like really only physicians can do this. But it'll be nice because by the time you guys get out, you can get special training, and you guys can basically prescribe opioids and things like that, which is a good thing, especially when access to providers can be difficult to get a hold of. So anyway, basically we have the Controlled Drug Act that requires registration with the DEA. So all of you guys have to be registered with the DEA, get your own DEA number assigned to you. And so sometimes you can actually work underneath the hospital DEA. It just depends on kind of what the set. I don't know if you guys have any special issues with the law or anything like that, but basically, I guess specifically, I don't know if you guys have issues with the law or if PAs have any special hoops to jump through as far as the law goes. But essentially, you guys will have a DEA that you'll be working under, and you'll be able to prescribe for these controlled substances. So there's 5 levels of controlled substance. We have 1, and again, all this is related back to what's their potential for abuse. Okay, so abuse meaning I'm going to be taking this because I like the way it makes me feel. So things that have a high abuse potential are going to have a higher scheduling. So things like Schedule 1, Schedule 2 substances, they have the highest amount of abuse potential. But what is the difference between a Schedule 1 substance and a Schedule 2 substance? And does it have a medical indication, right? So cocaine. Cocaine is a Schedule 2 medication because there are legitimate medical uses for that drug. Even though it's very highly addictive, very high potential for abuse, you can still use that for ENT surgeries, right? Because it's an anesthetic, it's a vasoconstrictor, all kinds of good things. On the other hand, marijuana, what is that scheduled? The Schedule 1, so federally it is still considered a Schedule 1 substance, right? So this is kind of one of those things where it gets a little iffy with the law, because now what did Florida do last year? Yeah, they're legalizing it for medical use. So technically, the government can still come down, and depending on who is the Attorney General, they can decide that, man, we really like to nab all these people smoking all these doobies. They are bad people. Let's put them in jail. It's kind of ridiculous, right? Because the abuse potential for marijuana is really not as high as you would say for, I don't know, methamphetamine. Probably not the same. Anywho, these are my judgment calls. But so essentially, the state said, hey, we can use this for medical use, and we're kind of getting everything set up for that. But the federal government can still say, hey, it's still a Schedule 1 substance. We're the DEA. We can come in and stop all this use. It's still considered to be illegal. It's just they choose not to enforce it. So that's kind of, marijuana is kind of an interesting use case there. But so again, no acceptable medical use, high degrees of abuse potential. Okay, Schedule 2 has an acceptable medical use, still high abuse. And then as you go 3, 4, and 5, they're going to find lessening abuse potential. Basically, it does not make you as high. It does not have as much risk for addiction associated with it. You'll honestly find that some of these are kind of arbitrary, and these can change over time. So look at some examples of that in just a minute. So again, some additional requirements for prescriptions for controlled substances. You need to have the name and the full address of the patient. We really need to make sure we know who this is prescribed for, so that way we can track things. Have I mentioned eForce before? So eForce is something all of you should sign up as soon as you get a license. It is made for healthcare providers and for pharmacies and pharmacists. And basically, it allows Florida to track where controlled substances are being filled at and who they're being filled by. Okay, it allows you to, a patient comes up in your ER and they say, hey, I got all this bad back pain. I need some oxycodone. I ran out. The dog ate mine, or I got stolen. Whatever it happens to be. And you can look up on eForce to see where specifically they last filled it, how much they filled, and so you can say, well, that's weird. You filled 200 like yesterday over in Tampa. Why are you asking for more now? Okay, and so at that point they can sheepishly try to run away from the ER and say, never mind, just kidding. Or they could have a legitimate need for it, right? So you can say, okay, well, I feel you're filling it every single month. Maybe something happened. Maybe you do have a legitimate need for it, right? So it's nice we can be able to track some of these things now. And again, Florida's kind of backwards on a lot of this stuff, so it took us a long time to get to that point where we could actually start to monitor these controlled substances. So that's a nice thing for it. But basically, I want to make sure we know specifically who it's going to be used for. If it's for an animal, and again, animals may have seizure disorders. They may need to be on certain controlled substances. You need to indicate the species there. So I don't think any of you guys are going to be vets, though, so you probably don't have to worry about that. Certain patients may be animals, but not in the literal sense. Then you put the full name, address of the prescriber, and then you'll also end up having your DEA number on there as well. That way we can actually go back and make sure that you're actually registered with the DEA and everything's on the up and up. Usually a lot of this stuff will be pre-printed on your prescriptions out there. And then need to have written and the numerical quantity to dispense. So you'll say like dispense 20 written out in TWENTY, and then 20 in parentheses essentially. So other kind of unique things, Schedule II substances cannot be refilled. So you cannot write for oxycodone, or in a lot of cases this comes up with ADHD medications. A lot of them are amphetamine based, which are Schedule II substances. And so you can write for potentially up to 90 days worth, because again, if you're writing for your or prescribing for a young child, the mom doesn't want to have to come back to you to get a new prescription every single month, right? It's kind of a hassle. So once they're kind of settled on their med and what their dose is going to be, you can write for a 90-day supply, and that way they can be basically only come back every 3 months or so. But you can't write for, take one time daily, here's 30, quantity of 30, and then you're going to write for 6 refills. Can't do that with Schedule II substances, okay? No refills. Now you can write for 3 separate prescriptions. That's the other thing you could do. So you could say, hey, do not fill until this date, and then you can kind of post-date them for individual months. You still want to write the date that you wrote the prescription on there, but you can say, hey, do not fill until this date, and we will follow that and honor those instructions. They have to be written on tamper-proof, tamper-resistant paper, which means they can't photocopy it. Otherwise, they'll come up with a big thing that says void, and I'll show you an example of that in a second. And they cannot be transmitted over the phone. So you can't just call up and say, hey, hook me up with some oxycodone, because I don't know you from Adam, essentially, right? So those have to be coming on actual prescription paper, and they have to really actually be signed. You can't just stamp your name on those. You have to actually sign them.
Is this Florida law or federal?
This is going to be federal law, mostly. Yeah. Florida may have a few other distinctions there, and I think you'll find these are pretty synonymous across the bunch here, right? And again, I'm not going to on a test ask you like, okay, what's the federal versus the state law on this, because that can be a little iffy. But this is in general. Here's how you guys are going to be prescribing, assuming you stay in Florida. Most of the stuff will still apply, right? So, and again, Schedule 3, 4s, and 5s, they're kind of handled separate from that. They can be refilled. But we mentioned for non-controlled substances, you can write up for a year, right? Those are good for a year. These are only going to be good for 6 months. Okay, so you can write for the first month and then write for 5 refills. For something that's like a C3, a C4, a C5, that's totally fine, and we'll honor that. Here's an example of prescription tamper-evident paper. It's usually going to be made by certain vendors, and they keep track of who is requesting this paper, and they make sure that they have valid DEAs and all of that. Because again, you don't want to send this out to every Tom, Dick, and Harry out there who can go and just write for their own scripts, right? And it will have all your information kind of pre-put on there. And if you try to photocopy this, you see all these voids on there. We would say, okay, this is a bogus script. We're not going to take that. And so again, there's a reason why they are oftentimes not going to be electronically transmitted due to that. Okay? And they have to be hand signed. Even some of this stuff you'll find it goes back to certain Medicaid regulations, to where especially if a high Medicaid population, like they will go back through and sometimes audit some of these things to make sure that everything is on the up and up. And so that's why, like for instance, over in Nemours, we have a ton of Medicaid patients. We make sure that everything that is controlled substance is on this tamper-evident paper. Make sure that way we don't run into any issues if we were to be audited later on. Okay, so I probably answered some of these already, but federally, what schedule do you think these substances fall into? So let's say morphine. Yep, that one's a 2. So most of your opioid narcotics are going to fall into be a Schedule II substance. How about cocaine? Already gave that one away. How about methamphetamine? It's actually a 1. So methamphetamine itself ends up being a 1, but you may find that a lot of other amphetamines, like dextroamphetamine or mixed amphetamine salts, they end up being a Schedule II. So it just depends on the particular one you're dealing with. We were talking about crystal meth. No. MDMA. That's Schedule 1. The marijuana, it's still federally considered a 1, even though state laws may they kind of laxed on that, and state laws may be able to because it's funny, like one of the first places medical marijuana was done was in the District of Columbia. So I could go smoke a joint, if I had a valid prescription in front of the White House, but can't use it recreationally. Who knows? We'll see where we're at in 5 or 10 years, and might be somewhere different. Okay, you may find that different states will have their own controlled substance list, and so, for instance, a drug called carisoprodol, otherwise known as Soma, this is actually a C4 in Florida, but it's not federally controlled in certain other states. So you may see that's a little bit of difference there, either based on we feel that there's a certain abuse potential, so we can add it to our state controlled substance list and make that a little bit different. And then some recent changes, tramadol, which is kind of a weak, kind of acting partial opiate agonist. This used to be unscheduled, but they found that there was a decent amount of abuse that was happening with it, and so they moved it up to a C4. So again, making the regulation a little bit more tight on it. And then hydrocodone, this is a huge sea change for us, because before hydrocodone was a C3, which means you could write for refills on it, which means you could potentially do electronic scripts for it. Very, very nice. Nowadays, it's a C2, right? Because the abuse of it, we're in the middle of opioid epidemic, as I'm sure you know. Huge problems there. So this makes it much more restrictive. This has been a huge problem for us from the ped standpoint, because if you think about it, pediatrics, they oftentimes use liquid medications, and so we have a liquid form of hydrocodone with acetaminophen, and we will prescribe that post-operatively for like a lot of our ENT procedures and things like that. And so not all the pharmacies necessarily carry that, because again, if you don't use a ton of it, you don't necessarily carry it. And so the parents would say, hey, let me call up CVS. Hey, do you have this hydrocodone in stock? And what does the pharmacy say? I'm not telling you that. Or we're out of it, we're out of stock, right? Because again, I don't want someone coming and robbing us. Actually, I got robbed my second day ever working in a pharmacy, which is why I went to the hospital and I said, if I get robbed here, then I'm definitely getting out of pharmacy and altogether. But because people will lie, cheat, and steal to get this stuff, so that becomes a big problem in trying to find pharmacies that would reliably stock the thing. So we could say, hey, go to this Publix here. This one, we already have an agreement with them. They're going to carry the this stuff for us. So things like that can be issues with and lead to changes in prescribing. All right, so any questions? That is the end of the material for pharmacodynamics. We'll do a review the next time, and then we'll have the test. All right, I'll give you guys a 10-minute break, and we'll come and do some physio.